Good morning. I'm Tomlin, Dean of the Faculty of Medical Sciences at the University of the West Indies, Mona, Jamaica. And it's my pleasure to welcome you all to the COVID-19 Approaching Red teleconference. And this conference is being done in collaboration with the Faculty of Medical Sciences here at the University of the West Indies and the Mona Information Technology Services. We met about a month ago when we hosted the COVID-19 Pandemic Preparedness Conference. And at that time, you recall there was no reported case in Jamaica. And indeed, very soon after that preparedness conference, we saw the emergence of the pandemic in the Caribbean. Today, we have the COVID-19 cases throughout the region. And as a result, we felt as a university that is leading in terms of science and research, that it's important for us to meet again, to share with our students, our faculty, the public at large, and the Caribbean, and the world, on where we are with respect to this pandemic. This morning, we want to share with you facts, we want to share with you science, we want to give you an update of the pandemic within the region and worldwide. And we're going to be looking at topics that are now relevant. It will still be preparedness, but now relevant to action and what we're doing. We're going to be looking at the issue of the natural history of COVID-19. What does the disease look like? And we have, also we're going to be looking at current therapeutic and pharmaceutical options. We'll be looking at the outbreak as it is occurring in Jamaica, the national picture, the epidemiological picture, and the question of testing, which is so important and relevant to control, will be examined in terms of what the role of the lab and what kind of tests and how do we test and so on. We also want to look at success stories, because as we grapple with the challenge of this pandemic and the stress and strain and all of the fear and anxiety, we've got to talk about the good news. Is there good news? So we're going to look at that this morning. We're going to look at the behavior of the virus from the time it left Wuhan in China to landing in our Caribbean region. And how has that virus behaved? Is it any different now compared to when it started in December 2019? We're going to look at the behavior of the virus, and in addition, very importantly, protecting our vulnerable population. We know that COVID-19 takes a toll across the board, but in the demographic analysis, we see the predominance and the impact on our elderly, our older population, and our vulnerable groups. So we'll talk about that. And importantly, this is a condition that is affecting our health, our personal health, but it's also affecting our economic health and well-being as a community. So we'll also this morning be taking a look at that in the context of what's happening to our economic outlook. And last but not least, it's about you. How are you responding? How are you coping as we approach Code Red? We talk about lockdowns and social distancing and so on. What is the social feel? What is the emotional feel? What's happening to us as a people at this time? We'll be talking about that. So we felt it's very important from the University of the West Indies to bring this conference here to you this morning as an update, but also as a point of saying we are in this together, and any little role we can play as a university to bring hope, to bring knowledge, to help us to cope better, we're right there with you. So I'm very happy to welcome all of our speakers this morning. And to be a host, I'll be introducing the speakers as they come forward to present. We have a panel of distinguished speakers, members of our university community, members of the National Ministry of Health and Wellness here in Jamaica. And it's my pleasure to welcome you all as we host the COVID-19 Approaching Code Red conference this morning. Ladies and gentlemen, our first speaker this morning at our COVID-19 Pandemic Approaching Code Red conference is Dr. Webster Car. Dr. Webster Car is the national epidemiologist. That's a big hat she wears. We've heard over the last month and going on in Jamaica, we've gotten reports, updates, numbers. We are tracking this pandemic as it goes through Jamaica and the wider Caribbean. And those reports that we get in terms of who is getting it, where, when, how, the distribution of the disease in our population, critical to the control of this pandemic and the mitigation comes from the efforts of our National Epidemiology Office. So we're very happy to have this morning Dr. Karen Webster Carr, who is going to share with us the COVID-19 Jamaica story as a way of getting us up and running as we approach Code Red. So let's welcome to the podium Dr. Karen Webster Carr.
Thank you, Dean. Good morning, everybody. Today we're going to talk a little bit about what is happening in Jamaica and on COVID-19. A little bit about the story and how it unfolds in Jamaica. So the World Health Organization has indicated 4 different phases of the outbreak: no cases, sporadic cases, clusters of cases, and community transmission. We went from no cases to sporadic cases on the 10th of March. And by the 14th of March, we were having clusters of cases. So clusters are grouped by time or place. But we have to say at this time that community transmission is imminent if it has not yet occurred. So the situation as we are right now is that we have 143 confirmed cases, 33 of which are imported. Within the last 24 hours, we had 18 confirmed cases. 33 imported, 37 of confirmed cases, 6 local cases that are not epidemiologically linked. That means we can't find the source. And so we say these are local cases. Then there are 67 persons under investigation, 60 of who work at a call center called Alarica. The sex distribution at this time is 39% males and 61% females, and the age range from 2 to 87. We'll talk a little bit more about that. But the new cases are, what we are seeing now is persons with influenza-like illnesses are showing up as cases. So our system is working. So who are we testing? We are testing all suspected cases, all symptomatic contacts to confirm cases, and we're testing asymptomatic contacts. All severe acute respiratory infection cases from all hospitals, admitted pneumonia cases from public and private hospitals, and all influenza-like illness. And there is a health worker surveillance that has been instituted in the last revision of the surveillance manual. So these are the results up to the 15th of April. We have tested 1,424, and we have 143 positive cases, a positivity rate of about 10%. The age distribution, what's been happening is that the Alarica cases are skewing Jamaica's data, because of the 143, 60 are related to the Alarica outbreak. This is a call center that has over 700 persons working, and so far 60 of them have been positive for COVID-19. And this is changing how our data looks. So if Jamaica overall, the mean age is 37 and the median 31. If we take out the Alarica cases, our mean age is 50 with a median of 49. And if we just include the Alarica cases, then the median age is 22 with a mean of 24 years. So you can see what the Alarica group is doing to Jamaica's statistics. So the sex distribution prior to the Alarica outbreak was mainly males, which is what is seen around the world. So for Jamaica minus Alarica, the number of males is 54%, but in Alarica, only 18% is male and 82% females. So the geographic distribution, currently St. Catherine is leading the way again because of Alarica. 91% of the St. Catherine cases are related to the Alarica outbreak. And then we have KSA. So only one parish is without a confirmed case at this time, and that is Hanover. And the lone St. Thomas case is from Alarica. So we have a number. This is just to say we're doing a lot of work, and we have been able to do some contact tracing, what person calls the shoelace epidemiology. We're going on the ground, finding all our contacts, and we're ensuring that they are tested, quarantined, whatever intervention to contain the spread. So this is the Alarica group. Already we see there are 2 contacts from this group. So geographically further look, this is the confirmed cases as of the 16th of April. If we look 2 weeks prior, we can see the change. So there are more darker spots coming up. And so you can see the transition that Jamaica is going through. This is related to the Alarica call center and where the cases are distributed so far. We are still testing related to this cluster. And just to see it probably a little clearer, this is the distribution for these cases. So, what are the symptoms? So far, we are able to give you for 125 of our confirmed cases. And what we did was group them by presentation. So fever and cough are the most frequently seen symptom. And fever and cough in combination is also the most. So fever by itself and cough by itself have equal amount. And the fever and cough combination has the highest frequency. So this is where Jamaica is at. The curve, as you see, we're going nicely along. Initially at about 5 days, then we went to 8 days of doubling, then we went to 9 days, then we were approaching 10 days when the Alarica cluster came up, and then we just shoot it up. If the red dotted line is if the Alarica did not happen, that is where we would have been as a country, but that's not where we are. So currently, we are at 5-day doubling of cases since the 14th of April when we went to 105 cases. So this is where we are, 5-day doubling. And we are still doing tests as we speak. So this may change in a very short while. So don't be surprised if I come back and tell you something absolutely different. So thank you very much for your attention.
Thanks very much, Dr. Webster Carr. So we've heard that as we start the conference, the story of the COVID-19 in Jamaica. The story is evolving, changing, very dynamic story, looking at what's happening in the recent days with the impact from the call center cases. And certainly what we're seeing is that the national epidemiologist and the team and her team are very busy. The very interesting slide, Dr. Webster Carr, with all of that data. I like the term shoelace epidemiology. Means you have a lot of foot soldiers on the ground tracking. I think that's one of the strengths, I'm sure, of the response is having that kind of intimate field work going on to for us to get a handle on what's happening. So we thank you very much for that presentation as we move forward with our COVID-19 pandemic conference this morning. Ladies and gentlemen, it's now my pleasure to welcome you to introduce our speaker who is going to talk on unraveling the natural history of COVID-19. And let me say before I welcome her, you know, every disease has a footprint, has a path that it takes. And you hear terms like, COVID-19 has been teaching us all kinds of epidemiological scientific terms. We hear incubation period, we hear asymptomatic, we hear recurrence and immunity and all of those terms. And the next speaker is going to bring all of that together to help us to understand what this disease looks like over time. It's the kind of photographic picture that the disease takes as it moves throughout the community. I'm very happy to introduce my colleague, distinguished colleague, I should say, Professor Celia Christie. Professor Christie is an infectious disease specialist. She's a pediatrician, and she has an outstanding track record in research. When we had the Zika outbreak, the Zika epidemic, the virus disease affecting our population, our children, Professor Christie was right at the front, running the task force for the University of the West Indies. Again, she sits on the task force for UE in terms of addressing the COVID-19 pandemic. And I'm very happy to welcome her to the podium to speak to us on unraveling the natural history of COVID-19. Ladies and gentlemen, let's welcome Professor Christie.
Good morning, friends, faculty, students, colleagues. This morning I'll be speaking about unraveling the natural history of COVID-19. Epidemics start at a moment in time. They proceed on a stage limited in space and duration. They follow a plot line of increasing revelatory tension, move to a crisis of individual and collective character, and then they drift towards closure. And these are the words of a very wise gentleman, Charles Rosenberg. The first signs of an epidemic are subtle. They are not acknowledged, whether it is because of economic issues or disbelief, until multiple illnesses and deaths herald the second sign, where the population then rises up, demanding explanations, and this ushers in the third sign, which sometimes leads to social disruption. Someone is always blamed. Governments then respond by exercising their authority with mandatory quarantine or a compulsory vaccination. This step generally involves people with power and privilege imposing interventions on people who do not have the power or privilege, and this adds to the social conflict. Another theme is that medical and public health authorities sometimes fail to live up to their promise. For example, smallpox took over 180 years for its global eradication, despite the fact that the appropriate vaccine was available. And so, a novel coronavirus recently emerged in China. Were we slow to recognize this threat? Did government officials try to suppress the early warnings? Have governments reacted with authoritarian interventions? Did quarantine fail to control the spread of this pathogen? Other concerns include stigmatization associated with epidemics, with the anti-Chinese hostility evident with COVID-19 outbreak of today. Second, epidemics often claim the lives of healthcare providers, and this is also shown by COVID-19 now. Healthcare professionals over the years have always been willing to put themselves at risk to care for others. But then should governments ask clinicians to confront outbreaks without giving them the appropriate personal protective equipment and putting them in the appropriate systems that they need to be successful and also to be safe? As Dr. Carissa Etienne, PAHO director, now warns us of the surge, or as she says, the blast ahead, how can we now continue to prepare? So let's remind ourselves of the origin of SARS-CoV. We'll remember this is a novel coronavirus and it causes COVID-19 disease. It was initially linked to a cluster of pneumonia cases in Wuhan, China in mid-December 2019. This virus was subsequently found in the respiratory secretions of 3 pneumonia patients. This virus is a positive sense single-stranded RNA virus, and phylogenetic analysis revealed that it falls into the genus of the beta coronaviruses. This virus, we feel, jumped from animals to humans, and although there's a lot of discussion, the mechanism is still unknown. It is felt that it went from bats and then through pangolins it entered into the human population. And this is evidenced by the genomic sequences being 96% identical to bat coronaviruses, and 10 genome sequences from 9 patients in Wuhan, China, which shared over 99.98% genetic homology with this virus. And so, as of yesterday, we know that we have over 2 million cases, 2 million confirmed cases reported in the last 10 weeks or so that we have been tracking this around the world. The death rate is about 6.7% of about 136,000 persons who have died. The United States tops the list with over 650,000 reported cases and 33,000 deaths. And in the UK, we have 5 countries, Spain, Italy, France, Germany, and the United Kingdom, which also are the next countries that are most involved, with numbers as you see there. The epidemic started in China, and so far we have about 82,000 confirmed cases reported there, with about 3,000 deaths. And it appears from what we're hearing that the epidemic there is slowing. WHO declared a public health emergency of international concern at the end of January, and a global pandemic was declared on the 11th of January, one day after Jamaica reported its first case. So far, we have over 210 countries worldwide and 2 international cruise ships that have been involved. The denominator, however, is uncertain. Why? Because these cases are confirmed and they're skewed more towards the severe hospitalized cases. Deaths from home or deaths in the community are not necessarily being counted, nor does the denominator include the several asymptomatic persons that are involved. Different countries also have different epidemics for a wide variety of reasons. So here in the Caribbean, we have over 4,600 cases and some 279 deaths for mortality of 5.5%. And the countries that are involved are shown here. Rep for 3,700 cases, Cuba, Guadeloupe, and then Jamaica had 353 cases at last count. Now, there are 8 strains of SARS-CoV circulating globally, but so far none of these 8 are more deadlier than the other. So of over 500,000 described cases to date, maybe there are about 1,000 genomes sequenced, many lineages are missing. Notwithstanding, it is clear that the phylogenetic trees show that SARS-CoV evolution is complex and extremely difficult for us to form a conclusion at this point in time. Transmission dynamics for this virus is not completely understood. We know that there is an incubation period of about 2 to 14 days with a mean of 4 to 5 days, and most people manifest symptoms of the illness by 11 days. The virus to date is detected in the respiratory secretions, blood, stool, and urine of affected patients. It is spread directly or indirectly by respiratory secretions, by when the virus touches the mucous membranes, the conjunctivae, the mouth, or the nose. The ACE receptors there invite the virus into the body, and you also have contact spread, which can occur from person to person through coughing or sneezing or talking. Aerosols in the healthcare setting are also important for airborne transmission. And asymptomatic and pre-symptomatic transmission has been shown. Some people feel it goes up to as much as 50 or even 80%, but this proportion is really unknown. And infectious diseases physicians would still say that most disease is spread by symptomatic persons. These viruses also live in the environment for 5 to 7 days. It's on the sole of our shoes when we leave our hospital to go home. It's on the computer mouse. It's probably on this podium as I stand here today. It's on sick bed, handrails, and so on. And we need to remember that. There's also the issue being reported recently that it's in the stool, and there's a possibility of fecal oral spread. Now, how does this virus present? Most persons will present with a fever and a cough, a dry cough, and they'll be having fatigue, and they will really not feel like eating anything. Some go on to have shortness of breath with sputum production. Others feel weak, and a smaller minority have headache, confusion, sore throat, and vomiting. More recently, we are noticing that nausea and diarrhea and abdominal discomfort may be the only signs and symptoms of this illness, and we wonder, could it be that these persons have these signs and symptoms but don't recognize it, and therefore they are being seen as asymptomatic? And more recently, loss of taste and loss of smell is also very, very prevalent. Of the 72,000 plus cases that were confirmed, suspected, or diagnosed in China, 81% of the cases were mild, 14% of those were severe with shortness of breath and respiratory distress and lack of oxygen, and 5% of the cases were critical. These patients had respiratory failure, they had sepsis or widespread infection through the body, they had cardiac injury and multiple organ dysfunction or failure. Patients who were admitted to the intensive care unit manifested what we call the cytokine storm as compared to non-ICU patients. Looking at comorbidities and mortality, among the first 44,000 cases that were found in China, you will see that the case fatality rate was 2.3%. And you will also see that the majority of the fatalities occurred in persons who were older than 50 years of age. They tended to have underlying diseases, more so in 30%, with the cardiovascular compromise, diabetes, chronic respiratory disease, and hypertension being the ones that were most involved. And this is evident by the graph that is shown in red at the right-hand corner of your screen. Of those who died, nearly 20,000%, nearly 20,000 of the confirmed cases occurred in persons who were less than 50 years of age, with only 64 deaths. I hearten, though, to add that in the epidemic that is now unfolding in other parts of the world, and in particular in the United States, a disproportionate number of young people less than 50 years of age are also being involved. Looking at special populations, luckily, pregnant women seem to be at no increased risk as compared to the general population. Children seem to be spared or mildly infected, and this data is being borne out in China, the United States, and Spain. And to date, there are still very few cases of mother-to-child transmission of this virus. Healthcare workers deserve special mention. In China, there was an initial cluster of 15, and then later on, of the 72,000 plus cohort, they found that there were 16 medical staff infected for a rate of 3.8%. There were 6 deaths there. In a study that was reported by the CDC just this week, they reported some 9,282 healthcare workers who contracted COVID-19, with 27 deaths in the United States. They hearten, though, that this is a gross underrepresentation because the population that they were looking at, only in 20% or so of them did they ask if they were healthcare workers. The president of the Medical and Dental Society of Italy said these events, of which he reports to 2,609 cases in healthcare workers in Italy and over 100 physician deaths. He says these events would have been largely avoidable if healthcare workers had been correctly informed and equipped with adequate personal protective equipment, the masks, the gowns, the gloves, and the protective visors, which in that setting continued to be in short supply. To protect our healthcare workers, we need to train them. We need to give them the materials they need to do their work well and to be safe. We need to screen them when they get to work. And in some cases, they've been offering hydroxychloroquine prophylaxis. Here you see on the right-hand side of this slide a decontamination system which uses hydrogen peroxide vapor to decontaminate N95 respirators. The process takes about 2.5 hours, and the mask can be cleaned and reused for up to 20 times. SARS-CoV-2 can also persist in respiratory secretions for 7 to 10 days in moderate cases and for 2 weeks in severe cases. It can persist in the stool for up to 37 days. Persons should be discharged from hospital when they're asymptomatic and they have 2 negative tests collected at 24-hour intervals. But all over the world, you're hearing that some patients recover, then they retest positive for the virus. And why is this so? This is being shown in Korea, it's being shown in China up to 14%, and even in Wuhan, where the epidemic started, in up to 10% of patients. Is this due to reinfection? Some feel that reinfection is unlikely. It is more likely, if anything, to be due to reactivation or late viral shedding. Some people feel that the tests are very sensitive and specific, and therefore they pick up part of the inactive debris of the now dead virus. They feel that maybe you could have an infection with a new strain of the virus, but that's unusual perhaps. But most people, they feel, will recover and demonstrate antibody to the virus, which should be protective. So what about prevention long term, and what happens in the end? So now there are over 60 vaccine trials that are currently in progress around the world. Phase 1, 2, and 3 clinical trials are being done to establish the safety and efficacy of these vaccines before we can approve them for widespread use in humans. Moderna is a lead product, and it should be ready for use in about 18 months. Now, should we vaccinate the world? Some are clamoring that we should have an immunity passport before we can re-enter the society. Meantime, we continue to implement social distancing, hand washing, mask wearing, homeschooling, teleworking. A third of the world is now on lockdown because of COVID-19. Even as Jamaica appears to be now heading for the surge, or what we call code red, or what Dr. Carissa Etienne calls the blast. Who knows? Another week? 2 weeks? 3 weeks? Whatever. It is time to bring all hands on deck, because everything and everyone will be needed to guide us through this now critical phase of the epidemic. Thank you for your attention.
I want to thank Professor Christie for an excellent presentation, taking us through the real facts about the epidemic, and it starts from China, what's happening now in Jamaica, and also looking at the important issues of the question of immunity. She talks about immunity passports and, some very interesting things. I'm sure we'll have lots of questions on that as we proceed. As much as COVID-19 is tied in very much with the public health response, and we talk about epidemiology, contact tracing, all of the interventions at the level of the health system, there comes a time when a person infected with the coronavirus may need, I should say, medical treatment in terms of medications, hospital care, and, God forbid, intensive care. And so today, at our conference, we're going to look at this aspect of the COVID-19 pandemic, the question of medications and therapeutics. And as you know, again, you would have heard from the public side, lots of discussions, interesting discussions about drugs, some of it being promoted by some of our leaders as to what might be working, etc. But we want to bring science into the picture, and we want to bring the evidence, and we want to speak about what works, what doesn't work, what we might use going forward. And so, ladies and gentlemen, this morning I'm very happy to have with us Dr. Kelvin Metalor. Dr. Metalor is a lecturer in the Department of Surgery, Radiology, Anesthesia and Intensive Care, right here at the University of the West Indies in Jamaica. He's an intensivist. And what that means practically now, he's the director of our intensive care unit at the University Hospital of the West Indies. So he's well placed to speak to us, being on the front line of managing the medical, clinical care aspects of COVID-19. He's in an excellent position to speak to us today on the current therapeutic and pharmaceutical options for managing COVID-19. Let us welcome Dr. Kelvin Metalor to the podium.
Thank you very much, Dean, and thank you, Prof. Christie. Thank you, everyone, for giving me the opportunity to share and to present our experience with the management of this very challenging disease entity. So I will go straight to what we'll be talking about this afternoon. This afternoon, we are looking at COVID-19, therapeutics, and pharmacological treatment. All right, SARS-CoV-2, as we all know it, of course, is a positive sense, single-stranded RNA enveloped virus that targets cells through viral structure spikes, the S protein. And these tend to bind to the angiotensin-converting enzyme receptor on the cell. So what we understand from that is that it definitely needs the ACE2 receptor in order for it to get into the cell. So following receptor binding, the virus particle uses the host receptor and endozymes within that particular cell to enter and to replicate. COVID-19, which is the disease caused by this novel condition, causes severe acute respiratory syndrome, and it presents an unprecedented challenge to identify effective drugs for prevention and treatment of this condition. Now, this is a complex journey, and definitely a roadmap is needed in order for us to be able to navigate this very treacherous road. So the clinicians need accurate evidence regarding the effective medical treatment, which is what is lacking because it's such a new disease condition. So you can just imagine that we are on a journey that we have never been on before, and at this point in time, we are trying to find our way around it. So most of the evidence that we have at this particular point in time are based on clinical experience and from trials from the countries that have been through this very difficult time. Currently, more than 300 active clinical treatment trials are underway. Many of them propose treatment plans, repurpose treatments, or experimental treatments for COVID-19. So a lot is going on as we speak. Never in the history of the world has there been such communication all over the world, whether from China, from Italy, from Spain, France, UK, United States, all over the world, people are putting in information together, trying together as a global village to tackle this enemy. Of course, it's also an enigma. And what exactly do we know at this particular point in time? We know that not all people exposed to SARS-CoV-2 are infected, and not all infected patients go on to develop severe respiratory illness. So having that in mind, we do know that SARS-CoV-2 infection can roughly be divided into 3 stages. Stage 1, the asymptomatic incubation period, plus or minus detectable virus. Depending on what point in time, you might not actually even detect a virus in this patient. They may be completely asymptomatic if it's very early. Stage 2, the non-severe symptomatic period with the presence of virus. And stage 3, which is the most feared stage, those that go on to develop severe respiratory symptomatic stage with high viral load. Now, what kind of response do we get? There is usually a 2-phase immune response induced by COVID-19 infection. Phase 1, incubation and non-severe stages, which is usually between day 1 and 5 of infection. And this tend to be, at least at the very early stage, the normal specific adaptive immune response that is required to eliminate the virus or to preclude the disease from progressing to severe stages. Now, for adequate endogenous protective immune response at incubation, at the very early stage, that's the non-severe stages, the host should be, 1, in a general good health, and 2, what is actually being looked on seriously at this particular point in time is the genetic background of the host. Now, your HLA, that's your histocytes, histocompatibility leukocyte antigen, that tend to elicit specific antiviral immunity. And from the lessons that we learned from H1N1 infection suggested that there are certain group of persons who actually will be able to, who are genetically predisposed to less severe infections when they are exposed to the H1N1. And they actually were able to sequence those persons that tend to have, just almost a natural immunity, and these are very important not just only in understanding the disease pathogenesis, but also in the development of vaccines for this disease. Now, why is this important? Because at these very early stages, immune responses, boost strategies, which we probably talk about later on, might be helpful. That's actually the suggestion. So you actually find that people have talked about all sorts of things that they have used to treat COVID-19 disease. So, I mean, from different continents, all sorts of information are coming out. People that have used black seed oil, people have used fever grass, people have used, you name it. There's something somewhere that somebody has used. And this actually, gives a lot of room for a lot of investigation, a lot of clinical trials, a lot of research, because we know definitely different things happen at different stages of the disease. All right. Now, immune response. This is war. Now, for other patients that may develop, whose immune responses may be impaired, they may go on to develop a viral pneumonia, and from there they may also end up developing a cytokine release syndrome type kind of response, or what's sometimes known as a secondary HLH. Now, these tend to occur approximately between 7 to 10 days into the disease course, and is usually characterized by severe destruction of the affected tissue, especially the organs that have high ACE2 receptor expression, such as the lungs, the intestines, and the kidneys. And these patients would tend to present with fever, with cough, with fatigue, with myalgia, dyspnea, and radiological findings that are suggestive of acute respiratory distress syndrome, the ground glass opacities that you normally would find. Now, specific markers of inflammation at this stage, or the non-specific markers of inflammation at this stage, including lymphocytopenia, neutrophilia, D-dimers, C-reactive proteins, and ferritin, your TNF, your granulocyte, macrophage, colony-stimulating factors, all these might increase, and then, of course, your CD4 and CD8 T cells many times will decrease. Now, there are other specific laboratory markers associated with specific inflammatory pathway, such as interleukin-6, interleukin-1, interleukin-10. And at this particular stage, some patients may actually go on to develop multi-organ failure as a result of the cytokine release syndrome or uncontrolled viral replication. So this really is war. So this is the stage that there's war on the human body. And all of these, of course, are soldiers fighting on the war front. That's the way I tend to look at it. Now, in terms of therapeutics and pharmacological management, intelligence is needed. In any war, you need intelligence. The therapeutics and pharmacological management of severe COVID-19 disease should be guided by scientific discovery and clinical data that has been generated by a large number of people rapidly infected by SARS-CoV-2. Like we said earlier, this is unprecedented. But what has been advantageous to the world is that there is such a rapid rate at which you can exchange information, excuse me, this day. So we are able to get information from all over the world, and everybody is putting in their experience, and that collective experience is guiding in terms of management. Now, pharmacotherapeutics should be guided by understanding of these stages and phases of the disease, namely the viral kinetics and the immunopathogenesis. Drugs and interventions are most effective when appropriately selected and timed. Now, when COVID started, all sorts of things were thrown at the patients at all sorts of times. Now, there were perhaps results that went that did not go down too well because we did not understand the viral kinetics and the immunopathogenesis of the disease condition. And so as time has unfolded, we are getting more understanding of how this disease behaves and what perhaps should be appropriately used and at what time. All right. So, of course, now what is in your armamentarium? What do you have to fight this war? So let's start with some of the more popular drugs, the chloroquines and the hydroxychloroquine. Of course, we've heard a lot about these so-called wonder drug. A lot about has been heard about it in the media, and it has generated all sorts of political, stuff. Chloroquine, hydroxychloroquine, a weak base, belongs to the 4-aminoquinolone antibacterial class. How does it work? It concentrates the acid vesicles of the parasites. It has actually been used a lot in treating malaria parasite. It actually concentrates the acid vesicles of the parasite and inhibits polymerization of heme. Now, in one of the studies that were done earlier on in COVID, it actually has been shown in some studies that one of the major ways that COVID tend to attack the cells is by actually affecting polymerization of heme and destruction of red blood cells by separating the oxidized ion from porphyrin. And so hydroxychloroquine, HCQ-CQ, seems to perhaps maybe play a little bit of a role in this. It accumulates in the lymphocytes and macrophages, resulting in anti-inflammatory properties, which is the main reason for its use in rheumatoid arthritis and other inflammatory diseases. It also increases the endosomal pH required for virus and virus cell fusion, as well as interfering with the glycosylation of cellular receptors of SARS-CoV-2. So HCQ-CQ actually, in a lot of in vitro studies have been found to be actually quite effective in reducing, viral replication. It also has immunomodulating effect, reduces T cell activation, differentiation and expression of co-stimulatory proteins and cytokines produced by T cells and B cells. However, despite the promise that HCQ-CQ has shown in vitro, it is quite uncertain whether it has actually, borne out that, whether that has actually shown itself in clinical studies. There's a lot of controversy. Perhaps there is no other drug that is more controversial than the HCQ-CQ. With studies from different places. Of course, we know the study from France. This was actually the study that actually popularized HCQ by Gautret et al. In France. The conclusion of their study was that despite its small sample size, the survey shows that hydroxychloroquine treatment is significantly associated with viral load reduction and disappearance in COVID-19 patients, and its effect is reinforced by azithromycin. Since then, other studies have come out, smaller studies. There's a study out of Brazil and then another study out of the United States that seem to have disagreed with this study. So the controversy rages at this particular point in time. Needless to say, in a number of countries, hydroxychloroquine, azithromycin is still in their treatment guidelines. The antivirals. Let's just start with the oseltamivir, Tamiflu, which is a neuraminidase inhibitor approved for the treatment of influenza, and it does not show any documented in vitro activity against SARS-CoV-2. Now, initially, why this drug actually made it to the headline is because at the outbreak in China initially, it was actually at the peak influenza season, so a large proportion of patients received empirical Tamiflu treatment until they were able to distinguish whether their flu-like illness was due to the flu or whether it was due to COVID-19 disease. So several of the current clinical trials still include Tamiflu in their comparison group, but not as a proposed therapeutic intervention. So this agent directly has no role in the management of COVID-19 once influenza has been excluded. What about lopinavir, ritonavir? This combination has also been shown to have in vitro activities against other coronaviruses through inhibition of the 3-chymotrypsin-like protease. Now, the timing of use of these drugs that affect viral replication should be borne in mind. Usually between days 7 and 10, when you actually have peak viral replication, is what is recommended. If you're going to use the drug, that is your best shot at it. Now, most of the studies that have been reported on this particular drug has been case report with small retrospective, non-randomized cohort study. It actually makes it difficult to ascertain whether the direct treatment effect of lopinavir, ritonavir is actually that effective. More recently, Carr and colleagues reported the results of an open-label RCT comparing the efficacy of lopinavir, ritonavir versus standard care in 199 patients with COVID-19. Their result was inconclusive. Another antiviral, favipiravir, which is a prodrug of the purine nucleotide. It acts actually by inhibiting the RNA polymerase, halting viral replication. Again, drugs that have shown a lot of promise in vitro. Most of the preclinical data for this particular drug were derived from its effects in influenza and Ebola activity. It has demonstrated broad activity against most RNA viruses, including the SARS-CoV-2. It is a lot of clinical studies are ongoing at this particular point in time, whether this drug will hold the promise as it looks like in vitro. Now, remdesivir is perhaps the most widely known, widely studied, and the most promising potential therapy for COVID-19 due to its broad spectrum. It has shown a potent in vitro activity against several non-CoVs, including the SARS-CoV-2. In a mouse model, remdesivir was effective when tested as a treatment for SARS-CoV-2, and also was tested in primates as well against MERS-CoV-2 and found to be quite effective. Now, it has been tested in humans for the treatment of Ebola virus infection and performed very well, but was said to be inferior to the human monoclonal antibodies. Now, there is currently a large trial going on. It's part of the drugs that is being used in the Solidarity trial, and a lot of institutions and countries have made allowance for its compassionate use in COVID or within the setting of a clinical trial. What about interferons? Again, another drug that has raised a lot of political clout, often referred to as the Cuban wonder drug. Now, interferon has been studied for non-CoVs, and it has shown a lot of promise again in vitro studies. Most of the published studies reported resulting from this therapy actually combined it with antivirals, and so that actually makes it a little difficult for you to know whether or not it was the drug or it was the antiviral, the combination. And the other problem with these drugs is that there's been a lot of side effects associated with it, and so it has actually limited its use. Now, given the conflicting in vitro and animal studies and the absence of clinical trials, the use of interferons has not been recommended, or is not being recommended by the WHO, the FDC, or the CDC, as well as other agencies. So they are actually at this point in time not recommending it. But I must hasten to mention that it is currently in the Chinese guidelines as an alternative combination therapy for the treatment of this condition. Corticosteroids, what I call the army chaplain. So remember now that we're in a war, so we are looking at the different aspects of it. So we have looked at the different things that are in our armamentarium. In any military setup, you always have an army chaplain. The chaplain tries to, take things down, make sure the soldiers are okay, and, counseling and all that is needed. Corticosteroid plays that role. The rationale for the use of corticosteroid is to host inflammatory response in the lungs, which may lead to acute lung injury and acute respiratory distress syndrome. That is how it is believed that hopefully it would work. Now, if you remember now that COVID-19 infection, we tend to go through 2 or 3 phases with the infection. There's the early phase where, you have the innate, the response, the immune response of the body. And then sometimes this response might get out of hand, and then you get, overwhelming response, cytokine release syndrome, or the SLHL kind of syndrome. Now, corticosteroid is reported to probably benefit in that regard. However, this benefit may be outweighed by adverse effects, including delayed viral clearance and the risk of secondary infection. That's where the problem has come from. Now, a lot of guidelines regarding the use of corticosteroids make it clear that if the patient is in septic shock, or there's any evidence of relative adrenal insufficiency, actually it should be used as needed in any critical care management. There are anecdotal evidence, but no conclusive published data on the use of corticosteroids, as well as several other immune modulators in patients who are critically ill with COVID, except for, of course, for those that show signs of severe CROS or SLH. Anti-helminths, the popular ones, nitazoxanide as well as ivermectin. These are, basically antihelmintic drugs with broad antiviral activities and relatively favorable safety profile. It has also demonstrated in vitro antiviral activities against MERS and SARS-CoV-2, but there are no studies at this point in time that are robust enough to lead to advice regarding the use of these drugs. The special forces, the anti-cytokines or immune modulatory drugs. Now, the monoclonal antibodies are directed against key inflammatory cytokines or other aspects of the innate immune response. Now, they actually represent another potential class of adjunctive therapy for COVID-19. Rationale for their use is that the underlying pathology or pathophysiology of significant organ damage, especially in the lungs and in the other organ, is caused by an amplified immune response and cytokine release syndrome, or the cytokine storm. Interleukin-6 appears to be the key driver of this dysregulated inflammation based on early case series from China. Now, so the monoclonal antibodies, especially IL-6, theoretically could dampen this process and improve clinical outcome. Tocilizumab, which is a monoclonal antibody specifically directed against IL-6, is actually approved by the FDA to treat rheumatoid arthritis and cytokine release syndrome following chimeric antigen receptor T-cell therapy, the CAR T-cell therapy. And a lot of features that you see in the exaggerated immune response in COVID-19 disease mirror that of CAR T therapy. And so this has led to a lot of interest in the use of this particular drug. Now, given this experience, tocilizumab has been used in small series of severe COVID-19 cases with early successes. Very quickly, a report of 21 patients with COVID-19 showed that the receipt of tocilizumab 400 milligram was associated with clinical improvement in 91% of patients as measured by their improved respiratory function, rapid DFFSS, as well as successful discharge, with most patients receiving just one dose. However, the lack of a comparator group limited the interpretation of the drug-specific effects, and it warrants caution until more rigorous data are available. Now, several RCTs are currently underway, and in the course of time, we perhaps might be able to get specific answers. Convalescent plasma, which is another therapy that is gaining a lot of ground in the management of this patient. Essentially, what we're basically doing is that you are taking plasma from patients who had recovered from the disease, and with the intention that these patients would probably have some form of hyperimmune immunoglobulins. And these plasma are directed against the treatment of COVID disease, especially in the phase of viral replication. Now, the rationale for this treatment is that these antibodies recovered from the patients may help with both free virus and infected cell immune clearance. Anecdotal reports have been encouraging, and the use of convalescent plasma is recommended within the context of clinical trial or for compassionate use. Now, very quickly before I finish, I will speak on just two very other things which directly may not be drugs, but they are things that are available in terms of therapeutics for the management of this condition. What is gaining a lot of rise these days is ECMO. I'll call that Terminator 3, the rise of the machines. ECMO is a form of modified cardiopulmonary bypass in which venous blood is removed from the body, pumped through an artificial membrane lung in patients, and returned back to the body. It's found to be very useful in refractory respiratory as well as in cardiac failure. Now, during the H1N1 crisis, ECMO came late on the scene in H1N1 crisis. But the studies that were done from a number of places where they have a lot of experience with ECMO, especially in New Zealand and in Australia, revealed that ECMO was very effective in the management of patients with H1N1. Oxygen is added, carbon dioxide is removed, and blood is returned to the patient either via another vein to provide respiratory support or through a major artery if the patient is also in circulatory shock. Now, the current WHO interim guidelines made general recommendation for the treatment of ARDS in COVID-19 include that consideration be given to referring patients with refractory hypoxemia to expert centers capable of providing ECMO. ECMO is very labor intensive. Those are the side effects of it. You know, you only need to use it in a place where you have a lot of experience with its use. Labor intensive, resource intensive in terms of blood and blood products being made available and staff. The machines are expensive. The things that you need for them are expensive, but the results so far that they are getting from ECMO are quite encouraging, and we will see what happens in the next few weeks. The other thing I'll mention finally is the use of hyperbaric oxygen therapy. Slowly gaining ground on the background is the evaluation of hyperbaric oxygen in the management of patients with severe hypoxemia. Now, physiologically, it makes sense. We know that one of the things that happens in these patients is that they are very hypoxemic and oxygen delivery is difficult, and so cells are deprived of oxygen. There's an uncoupling of the FiO2, PaO2, and FiO2 PEEP, and so you find that patients might be looking at you and be severely hypoxemic until they fall off the ladder. Now, there's a study in China where actually, of course, this all began. They actually employed the use of hyperbaric oxygen in treating 5 critical patients, and that showed severe COVID-19 disease, and they actually had very excellent results with it. Now, this graph basically just takes us through how COVID-19 essentially behaves. You know, that's, of course, is the virus there. If I can get my, okay, that's the virus, the SARS-CoV-2 virus there. You know, of course, the ACE receptors, ACE2 receptors that it tends to need in order for it to gain access to the host cells. And this is an excellent, an excellent schematic diagram, an excellent diagram showing you basically the various stages that various things would tend to act. Like we understand or said a little earlier, I mean, a lot of mistakes that were made in the management of COVID-19 in the early phases was, people were walking just in the dark, and indeed it was dark because it's a road that nobody really had been before. It's a novel virus, and so people we were trying all sorts of things. Over the period of time, the disease pathogenesis is becoming a little clearer, and there's a bit more understanding, and people are beginning to understand what to use, and more importantly, when to use it, so that we can actually affect the outcome in patients. In my conclusion, currently the World Health Organization Clinical Management Guideline documents, as of March, states that there is no current evidence to recommend any specific anti-COVID-19 treatment for patients with confirmed COVID-19 disease. So the World Health basically recommends supportive therapy. I mean, there are lots of things in the armamentarium. Many of them are undergoing large-scale clinical trials, many things that are showing promise. The challenge really has been to know what to use and when to use it. And I'm quite confident, that the current mega trial that is being put on by the WHO, called the Solidarity Trial, which is a pragmatic trial that is designed to randomize confirmed cases into either standard care or to one of 4 active treatment arms. One arm, remdesivir, one with chloroquine, hydroxychloroquine, lopinavir, rotenavir, or ropinavir, rotenavir plus interferon beta. Now, this trial is ongoing, and we are actually a part of this trial at the University of the West Indies. So we are plugged into the trial. We will be supplying data, and so we will be using some of these drugs in our patients within that context and be sending in the results to the World Health Organization for analysis. So we are confident there is light at the end of the tunnel. There are ways. It's a war, and of course, like the good book says, it is by wisdom and by counsel that you wage a war. Thank you.
Thank you very much, Dr. Metallo. What an analogy. It's a war. Really liked how Dr. Metallo put the various drugs and levels of intervention in terms of the context of the war. I'm very happy to see the chaplain on board. We have a question, Dr. Metallo, from a member of our audience. This person says, we've heard a lot in the fight against COVID, we've heard a lot about ventilators, suggesting that ventilators are critical and life-saving part of treatment. Where ventilators are scarce, there's a lot of fear and concern. Could you say something about the value of ventilators and how they work in the treatment of COVID-19 patients? If you take that question for us.
Thank you, Prof. You notice that I actually specifically stay away from ventilators because I know that so much has been heard about ventilators. Now, of course, we absolutely need ventilators. We do need ventilators because there are going to be patients who would need to be ventilated while they are undergoing treatment. Now, unlike the earlier phase where, it was just ventilate, 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 we are now beginning to understand that we ventilate with caution. Now, patients will still need to go on ventilator, and it has a role for patients who, despite all that you have done to stave the patients away from ventilator, there will be some patients that will still need to be ventilated in their support as part of their management. Now, the current role of the ventilator is that for patients who you cannot manage otherwise, patients who, despite everything, non-invasive oxygen therapy mechanisms and everything else that you have done, then you will go ahead and ventilate. The reluctance or the change in the paradigm as far as ventilators are concerned has been born out of the fact that a lot of studies have shown that as soon as patients go on the ventilator, and if you look at the disease pathogenesis, you would realize that most patients are about to fall off the cliff between days 7 and 12. And that is the time when the cytokine storm is in full blown. Now, when you put these patients on ventilators during this period of time, you will almost invariably add more cytokines, pulmonary macrophages, on a background where you are already dealing with an oversaturated body. And the crosstalk between the lungs and the kidneys tip them over and they end up in acute kidney injury. And sometimes, if you're not careful, it's going downhill from there. So we are now circumspect in how we ventilate these patients. Not only when to put the patients on ventilators, but also how we ventilate the patients as well. Yes, it is still very relevant. We still do need ventilators, but just that we are using it a little differently from how we initially thought it could be used at the beginning of this pandemic. Thank you.
Thanks very much, Prof. And I must say, I want to thank the audience for tuning in, for their questions. I want to thank this is a conference put on, as you know, by the UWI, University of the West Indies, Faculty of Medical Sciences at the Mona campus in Jamaica. We're doing it in collaboration with the Mona Information Technology Services. And we're happy that we have a mixed audience. We know we have doctors, nurses, physicians, but we have members of the public out there. And so I thank you for the question on ventilators, because that's in the press, it's in the news, and very well handled by Dr. Metalor. So let me thank you, Dr. Metalor, for presenting to us really an excellent picture of the therapeutics and the treatment options for COVID-19. What we're hearing is that there really is no specific recommended treatment at this point in time, but a lot of work is going on. Our University of the West Indies is a part, you said, of the Solidarity trial, which is a global trial out there, and we look forward to updates on this as we go forward. Thanks again for joining us in this conference. It's now my pleasure to introduce our next speaker. And before I do so, I just want to, the speaker is going to talk about, the topic here is who to test, with which laboratory test, and when. And we know indeed that the question of how do you know that you have COVID-19? Well, there's signs, and you heard Professor Christie gave a list of the signs and symptoms and, coughing and so on. And that's one way to diagnose it, and we talk about it as a clinical diagnosis as physicians and doctors. But there's another way to look at the question of how do you know you have COVID-19? And what is important here is a question of doing a test, a laboratory test, which is more definitive and very focused and specific in terms of giving us the answer to that question. And indeed, as you've seen the worldwide discussion, the wider discussion out there about the role of testing, not only in telling you whether you have it or not, but in the context of controlling and managing the public health response and managing the epidemic. The question of testing is critical at this time. So it's my pleasure to introduce our next speaker, Dr. Joshua Anzinger. Dr. Anzinger is the director of the Jamaica Affiliate Global Virus Network. He's also the head of virology in the Department of Microbiology here at the University of the West Indies in Jamaica. And he's a senior lecturer in that department. And he's a member of the UE COVID-19 task force. So as a virologist, and given the role he's playing, he's very well qualified to come and speak to us and guide us through this phenomena, what I'll call this phenomena of COVID-19 testing. Let's welcome Dr. Joshua Anzinger.
Thank you so much for that generous introduction, Dr. Paul. So I am being asked to talk about basically the lab testing. I'm going to talk mostly in general about the types of labs tests that are going to be available, what they are, their role, but I'm also going to talk about who to test briefly and also when to test as well. So in terms of who to test, we have to go by some sort of case definition, and many countries throughout the world, including in this region, have adopted the WHO case definition, which is as follows. You have to have one of three things, and here is the first one. A is a patient with acute respiratory illness, with fever and at least one sign or symptom of respiratory disease, and a history of travel to or residence in a location reporting community transmission of COVID-19 disease during the 14 days prior to symptom onset. Obviously, this has now become a little less important than the next two definitions because basically you have community transmission all over the place in the world, and of course all the travel restrictions. What's become more important is B and C. So another possibility is a patient with any acute respiratory illness and having been in contact with a confirmed or probable COVID-19 case in the last 14 days prior to symptom onset. And finally, or C, a patient with severe acute respiratory illness with fever and at least one of the signs and symptoms, as well as hospitalization, and in the absence of an alternative diagnosis that fully explains the clinical presentation. All right, so for all of these are people that are symptomatic, and these are recommended that these be tested, these people be tested. But of course now this is very problematic because there are so many infections throughout the world, and there may not be enough resources. Even in those countries that are very, very well resourced, we're seeing issues, and even the CDC has a prioritization in terms of who to test. So this is actually adapted, I should say, from the WHO guidelines down there. You can find in the lower right. I've also added the asymptomatic on the right. All right, so this is a priority list. If we don't have basically the capacity for whatever reason, we don't have enough swabs, we don't have enough reagents for lab testing, et cetera, then you need to begin to prioritize. All right, and of course the highest priority is going to be those that are hospitalized suspect cases. And then those that are the healthcare workers that are treating these people, whether they be identified as a contact or no known contact, these are the next highest priority. Following this, then we have in a closed setting, our first symptomatic case in a closed setting. This could be, for example, in a school. It could be in our call center, as we've seen in Jamaica now, this notorious call center, which tipped off now this first case and now investigating basically the entire call center and sampling them. We then can go now to our mild suspect cases, which obviously are much less of a priority than our hospitalized suspect cases. But just because you have a mild case does not mean that you won't end up in the hospital. All right, so there's priorities there as well. And so with your mild suspect case, we can look at those with risk factors versus those without risk factors. And Professor Christie talked about some of those risk factors already. Cardiovascular disease, we're seeing obesity appears to be a problem in the US, chronic respiratory disease, diabetes, these are risk factors, as well as the elderly. So we know someone that's 80 years old is going to be at much greater risk than someone, say, that's 10 years old. And then we go all the way to the right and we see asymptomatic is going to be absolutely the lowest priority. All right, and we can actually look at this a little bit further. I didn't include it here. You can have a targeted or untargeted asymptomatic approach. Untargeted, basically you're testing everyone. Or you could have a targeted approach. So if we go back to that first symptomatic case in a closed setting, again, the call center, you can, if you have the resources, this would be a targeted approach looking at asymptomatic people. So you can target, you can look at people that are symptomatic, but you can also look at asymptomatic in that closed setting, which would potentially give you lots of information on people infected. We could have people that are asymptomatically infected, et cetera. All right, so unfortunately we have to prioritize these. Basically, most places throughout the world have to prioritize who's going to get the test. And what are the lab tests? Basically, right now, it's broken up into 3 general lab tests. So in terms of individual tests, there is a plethora of tests now on the market. There's over 120 tests. All right, I'm not going to talk about specific tests, so I'm just going to talk about general tests for the most part. And so we break this down on the left. This is our molecular approach, which is going to be amplification of nucleic acid, the genome of the virus itself. We have rapid tests, as we see in the middle. As we might guess, these are tests that are going to offer very rapid results. And on the right, we have serological approach. All right, so our serological approach is going to look at antibodies. And our rapid, typically we have one of 2 different general approaches for rapid, an antibody-based test, and that is all that is there for COVID-19 at the moment, and an antigen-based test, which as of yet there is not a antigen-based test for COVID-19, but there are some that are being developed. All right, so getting back to our molecular tests here, this is really going to be one of the most important now. This is going to be our best performing tests. All right, so we can see this is a real-time PCR instrument here on the left, and this doesn't look like much. This machine is maybe 1.5 feet tall, and it doesn't really look like much is going on, but the inside is a completely different story. It's a very complicated piece of machinery, a very, very expensive piece of machinery. And this is going to take something like a full workday to do the test, right, by a traditional PCR approach. So now everybody's basically heard about PCR as a diagnosis. This is going to be the traditional test, but we're also starting to see some rapid molecular tests. I'm going to talk about that briefly, which could take even on the order of a handful of minutes. Our molecular tests are really going to be the tests we want to use for diagnosis, all right? We're going to be able to detect the virus at all times during disease, basically, if we're taking the right samples. We also have great flexibility for their molecular tests. We can use different sample types, all right? We can assess a nasopharyngeal swab, a throat swab. We can even look at stool. Wherever the virus is, we're going to be able to look at it with our molecular tests. These are the best tests, all right? These are the highest sensitivity, highest specificity tests, all right? Now, the one issue with our molecular tests, though, it do not provide information of past infection. All right, so once the virus is clear, its genetic material is clear, then we have no trace of it to detect it by a molecular test. All right, and this is where our antibody-based approach would come into play. All right, I'm not going to talk to you really about the details of the molecular test, but I do want to really have people appreciate the time that goes into these molecular tests is quite a bit of time and lots of hands-on work. And so most of these traditional PCR tests are going to be very time-consuming. So I'm showing here, this is based off of the WHO recommended real-time PCR test. And this can be broken up into 4 different general sections. So we have the sample that we're processing. We're removing the virus from the swab. This is going to take something like 30 minutes for 24 samples. And so we usually use 24 samples because that's the amount of space that you have in one of our microcentrifuges. So that's the reason for 24 samples. Where then once we have now removed our virus from the swab, we have to extract, go through this process of extraction, where we're going to isolate genetic material. And this is really a big bottleneck. All right, so if we look on the right, to process 24 samples for extraction, it's going to take 1.5 hours about manually. If we have some sort of automated instrument, like a robot that's going to process these samples, 96 samples at a time, it's going to take something like an hour. All right, so we can see the very, very major difference with automation. We then now have to make basically all of the master mix. We put all the components together, including now our virus, and we're going to be ready to go to put it in the machine. So this is going to take about 45 minutes. Then we're going to have to do the final step. We put everything together in a little microtiter plate. It goes into the machine for amplification. So we have to detect the virus by amplifying it within the machine. And this is going to take an hour for the screening about. All right, and then once we have a positive, now we have to go back and do it. There's a confirmatory test. This takes another hour, plus another 45 minutes to do the master mix again. So if we run through this for one person here, the total time is going to be 11.5 hours for manual extraction to do 96 samples. With automation, this is going to cut it almost in half, 6.5 hours for 96 samples. All right, so we can see, we can appreciate how long this process takes to actually do this. And we can actually speed this process up if we have now enough work areas. If we go back to the extraction, the manual extraction, for example, if we only have manual extraction, we can add 3, 4 more people. And within that hour and a half, if you have 4 people, then we get 96 samples processed, all right? So this is really the big bottleneck, is the extraction for our traditional molecular test. Now, fortunately, in the last decade or so, there have been platforms that have been introduced that are molecular testing platforms that are rapid, all right? And here, these are probably the three most popular ones. On the left, we have the Abbott system, and this is going to be completely point of care. It can be right within the hospital. So basically, you have a little cartridge that you see on the left there. You're going to insert your swab in that little blue area. You close everything, you start, you get a result in 15 minutes. This is going to be really, really very good to have if you have a limited number of patients coming in, for example, in a hospital. But you can see if you have 100 patients, this is going to take forever to go through this, and it's going to be not as useful. If we go to the middle now, we have now increased throughput, meaning that we can get more sample results in our unit of time. So this is the Cepheid Gene Expert, and this comes in a number of different sizes. As you might imagine, the bigger the better, also the more expensive. So on the left, you have a single module approach. So each cartridge does one swab. It takes 45 minutes to get an answer. If you look to the right, we have a 2-module system, 4-module, and then 16-module. Not shown here is the gigantic system, which is very expensive, that can do 80 samples in 45 minutes. If we look now on the right, we have the most high throughput system here, and this is the Roche Cobas system. And basically, you load this up, and within 8 hours, you get 384 results for 384 samples. And this is a machine that actually has just got installed, a new machine at the Public Health Lab here in Jamaica. And they also have reagents for this, I understand. And so this will greatly increase testing capacity, hopefully. I should say that it's very difficult to even get these machines. They're very expensive. Some of them you can't even get right now. So, for example, the Abbott and Cepheid, these are not being allowed to use leave the U.S. is my understanding now. So even getting the instruments themselves, but on top of that, getting the reagents themselves is also being held up as well for some of these. So it's very difficult, even just if you have the machine, to get the reagents now to do the tests. All right, so that was our molecular tests, and now we go to our rapid tests, which of course have been big discussion now as possible game changers, because anyone can do it. You can get a result in 15 to 30 minutes. These now, unfortunately, are typically notoriously of low sensitivity in general. Before these COVID-19 tests, other viral tests, they're notoriously of low sensitivity. And that means many infections are going to be missed, unfortunately. So as I said, for our rapid tests, this is going to be a blood sample because we're looking for antibody. There is as yet no rapid test that's actually looking at the components of the virus. They're in development, though. The specificity could be an issue. These are brand new, and many of these have not been assessed at all in terms of their performance, and the specificity really could be low, and this could potentially lead to a misdiagnosis and false sense of security that perhaps you have been infected now and possibly you're immune. Another problem, even with the absolute perfect test, a perfect rapid test, is we don't have antibodies appearing till about, on average, a week after symptom onset. So even with a perfect test, if we're going to use a rapid test and we're less than 7 days after onset, we're never going to get a positive. All right, so we're always in that sense going to get a false negative. So this has really greatly limited the use of rapid tests and really would only be useful for late in the disease process. Finally, the last type of test type is serological tests. This is our antibody-based approach, which is a lab-based approach. So all of these things have to go through a lab. This is going to take, depending on the system now, some automated approaches like the middle there, the Architect approach, Abbott Architect, can take minutes to get an answer to one sample. On the top, we have an ELISA-based approach, and then we can also even have a culture-based approach, which is going to be very, very time-consuming. We have biosafety concerns. It's going to be a very tedious process. You're not going to get answered for many, many days. All right, so these are really typically not done in diagnostic labs. And again, this is going to be, our blood sample is going to be antibody. We also need, just like our rapid test, to be mindful that we're not going to get antibodies appearing until about, on average, a week after symptom onset. Most of these tests have not been independently evaluated, and this is a theme really for all, the majority of tests that are coming out. There's really only a minority of them that have been independently evaluated. And I've underlined here, these are very, very important, potentially, these serological tests now in terms of public health, having a good test, because this can identify now people that are infected in the past. And we talked about this possibility for immunity passport, Professor Christie talked about, and so this could really guide that potentially if that comes into play. And this could also really tell us the population level. That's really a mystery now. How deep is it in all of the countries? We don't really know, because we're primarily looking for cases that have symptoms. We know there's asymptomatic. So how many people are actually infected? A serological test will actually be able to answer that, a good serological test, because we can take a sample representative of a particular population, whether that be a particular town, maybe that be a country, and we can see the relative level of infections that are present, or people that have been infected in those populations. And then this could also indicate some degree of immunity. Of course, we don't know for sure. That's an open question. Likely that once you have antibodies, once you have some degree of immunity, that will have some effect if you're able to be reinfected. Likely the severity will be lower if you're infected, or perhaps we're not able to be infected at all. But again, that is completely unknown at this time. All right, so when to test, and this is the only hard science slide I've included, but I think it's an important slide to include. So this was of a fairly recent publication, and this was looking at hospitalized patients in Germany. So each one of these graphs now represents an individual person. On the x-axis, you have days after symptom onset, and on the y-axis, basically, you're looking at a positive result. All right, so above the dotted line is indicating a positive result. We have 3 lines here, and so we have our yellow line, which is indicating the results of a nasopharyngeal swab. On our orange line, we have the results indicating the results of sputum. All right, so a nasopharyngeal swab is an upper respiratory tract sample. Sputum is our lower respiratory tract sample. We also have in gray, this is stool. They actually looked at stool here, and you can see it can be detected in stool. I won't show the data here, but they did not find any infectious virus from the stool. So they did find the genetic remnants, but they weren't able to culture and find any infectious virus, which of course has very good implications in terms of not being spread fecal to orally. But they did find infectious virus, of course, in the respiratory tract from these samples. So if you'll notice here, we have a difference. We don't have a perfect match. Sometimes we do, in terms of our yellow nasopharyngeal swab, or upper respiratory tract, and our sputum in orange, our lower respiratory tract. So you'll notice that basically at all points early on, you're getting positive results with your nasopharyngeal swab. But later in the course of the disease, for many, that is disappearing. So you see it's going below that dotted line. Yet we're still seeing it now in the sputum, all right? So if we're taking the right sample now, we should be able to detect it all throughout the disease course for our molecular-based testing approach, as we can see here. The last point I want to make about this slide is that we have this arrow up here. So let's not worry about the IgM, IgG, but the arrow up here that we see, this is going to indicate when we have antibodies appearing, all right? So we can see that it varies from person to person. On average, is about a week after onset of symptoms, antibodies develop. And so this really shows us the limitations of antibodies in diagnosis, especially early on. This is not going to be a good test to use, and antibodies are really going to be more important for looking at past infection. All right, so for our molecular, as we see on the right, we can use this test, when to test, after onset of symptoms all the way up to resolution. But we need to be mindful of the fact that it can disappear from the upper respiratory tract. What now appears to be is known is that we get the infection, the upper respiratory tract, it appears, it replicates there, and then it goes down to the lower respiratory tract, and it can disappear from the upper respiratory tract. You'll also notice that we have periodic blips maybe in the upper respiratory tract where it becomes now detectable. And this could be for a number of reasons. It could be possibly even due to how the sample is taken and preserved and transported to the lab could even be one potential issue. So when to test, all the way throughout the disease course, molecular is going to be the useful approach, the best approach, the most sensitive, the most specific approach, and that's why we're seeing so much emphasis on the molecular approach. Our rapid, remember, at this point is all antibody-based, so it's basically the same as our serological, is going to be at least a week after onset of symptoms. All right, and remember I talked about a serological approach can be very important for identifying people that have been infected in the past and looking at population level exposure. All right, so just to summarize what I've said, the who, what, and when. So the who, we look at suspect cases, and we may have to prioritize. Basically, almost every country has to prioritize who they're testing, with, of course, asymptomatic the absolutely lowest priority. What are the tests? So we have the three general types. We have the molecular tests, which encompasses PCR that we've heard so much about. These are the most definitive tests. These are the tests you want to use throughout the disease course. We have rapid. These are fast, but generally speaking, they're of inferior performance to our lab-based tests and really have a limited role because the antibodies are really not appearing till at least a week, and possibly the sensitivity and specificity may not be very good of these tests. Finally, our serological tests, as I said, are going to possibly be very, very useful for identifying people that have been infected in the past and seeing population-level exposure. So the when. Throughout the disease course, as I've said, molecular testing is really going to be the cornerstone that we want to rely on. We could possibly, late in disease, look at rapid and serological testing because antibodies are starting to become available. And then no disease is really a difficult thing to do because we don't know. Perhaps you're asymptomatic. A molecular test would be useful. Perhaps you have cleared the infection. You've been infected in the past, and in that case, a rapid or serological approach would be most useful. So I will finish there, and thank you again for the invitation to talk a little bit about the lab.
Thank you very much, Dr. Enzinger, for really giving us very clear insights into what I call the phenomena of testing. Certainly, there's been a lot of discussion in the public media about testing and its role in terms of identifying patients. What I'm hearing between yourself and Professor Christie is that the question of can we get it again? That's a question the public is asking. We've heard reports in other countries which appears though one can get it twice. But I think that question, both between Professor Christie and yourself, remains unanswered in terms of any clarity. There's still room for research, for us to look at the science again very clearly. I like the fact that you showed that depending on when you test and what you test with, you may or may not find the presence of the condition. I think that was really well presented. So I hope the public, I hope we are clearer on that. And as we go forward, we look forward to the emerging science and the data that will bring further clarity to this issue of testing. Thank you very much again, Dr. Enzinger. So we recall that in December 2019, we saw the coronavirus in Wuhan, China. And since then, we have seen COVID-19 moving through countries worldwide. The concept of a pandemic: Singapore, Korea, Italy, USA, Jamaica, Trinidad, and the Caribbean. And everywhere, we are rushing to contain, to control, and mitigate this epidemic. Are we winning the fight? You know, in the Caribbean, we are people who we are accustomed with winning. We have athletes, and I don't need to list all of our athletes who have won and done well internationally. And we are people who work hard, and we are people who look forward to succeeding. So with respect to the COVID-19 pandemic, today we're going to look at success stories in the containment and control of COVID-19. And some of you may be saying, are there any as yet? Well, there's no better person to share with us to answer this question than our Professor Peter Figueroa. Professor Peter Figueroa was a member of when we did the pandemic preparedness conference, he spoke. Professor Figueroa is Professor of Public Health, Epidemiology, and HIV here at the University of the West Indies in Jamaica. And last year, the World Health Assembly recognized him as a distinguished public health leader of international reputation. Ladies and gentlemen, my pleasure to introduce Professor Peter Figueroa, who's going to speak on the topic, Success Stories in the Containment and Control of COVID-19. Let's welcome him.
Thank you, Dean Tomlin Paul. I'm going to share the success stories of the containment and control of COVID. So my objectives are to review the successful responses and share the international experience, lessons. The overall aim is really to empower ourselves and the people so that we can have an effective public health response to the pandemic. This is a model of the coronavirus, which is known as SARS-CoV-2, and it causes the coronavirus disease. We now have over 2 million reported cases globally, with over 140,000 deaths. And most cases have been reported from the United States, well over 500,000 cases, 34,000 deaths. And in various European countries, there have been over 100,000 cases reported in these countries, and thousands of deaths. The overall death rate is about 7%. However, it's quite likely that the true number of cases are much greater, that the number have been underestimated, and therefore the death rate is probably much lower than 7%. Now, Germany, you will see here, has a death rate of just 3%, and this is because they acted very proactively, as well as you will know that their leader ensured that only 2 persons from separate households could be outside together in public. So they really restricted the mingling of people. This is the epidemic curve in China up to the late February. And the first curve in blue is really it's done by the onset of symptoms, the date of onset of symptoms. And the second curve, further to the right, is by the date of diagnosis. So you notice there's always a lag period between the diagnosis and the actual infection, when the infection takes place. So the epidemic is always ahead of what we are seeing. Now, the joint WHO-China report that looked at the epidemic in China said that China rolled out, and I'm quoting from the report, perhaps the most ambitious, agile, and aggressive disease containment effort in history. They had universal temperature monitoring, masking, and hand washing, suspension of public gatherings, stay-at-home requirements, travel bans. The people were very disciplined and adhered to the containment measures. But what many people don't realize is that they had massive mobilization of thousands of volunteers to help. So their bold approach changed the course of the epidemic and gained time for other countries to prepare. And China's experience provided vital lessons to the rest of the world. Now, local officials in China may have been slow in reporting the outbreak initially. However, the Chinese isolated the virus causing the disease, and within 1 week were able to sequence the genetic code, and they shared it internationally. So they were able to develop diagnostic tests rapidly, but within 1 week, a company in Germany was able to also come up with a diagnostic test because of the sharing of that genetic code. There was aggressive contact tracing, testing, quarantine, isolation, and treatment. They were able to build 2 new hospitals in 2 weeks. They set up isolation areas in stadiums and gymnasiums. And there was a total lockdown of Wuhan, 11 million persons. Now, when they realized how aggressive the epidemic was in Wuhan, 40,000 health providers from throughout China volunteered and were mobilized to help in Wuhan. And they were isolated, they stayed in one place, they worked round the clock, and not one of those health providers became infected. Other health providers in the early part of the epidemic did become infected, but none of the 40,000 that we're aware of. They used thousands of volunteers to do things like fever surveys, contact tracing, and volunteer in other ways. So there was significant task shifting. and 15 million people had to order food online, and it was delivered by volunteers to their homes to show the extent of the mobilization of the people. Of course, there was significant use of technology and research. What did we learn from the epidemic in China? We are all susceptible. Cases among children are rare. Young adults rarely get seriously ill. It's the rare person who is young who gets ill. Most persons will recover. Some persons, although they recover, they may remain infective up to 37 days. The elderly are the ones who are most at risk, especially those with comorbid conditions. Health providers caring for persons with COVID must take special precautions. The clinical features were described, primarily fever, cough, fatigue, sputum, shortness of breath, sore throat. Now, it varies a bit in different countries. Some countries have more GI symptoms, nausea, diarrhea. So it does vary. And in more recent times, we are seeing that one of the early signs is loss of sense of smell. It may be the first symptom of COVID. Now, 80% of the cases in China were mild or moderate. 14% were severe, and 6% were critical. It was among the very old, those over 80 years of age, 22% of them, unfortunately, who became ill and had to be admitted to hospital, actually died. But most persons, in fact, will recover. Again, in China, we were able to identify the clinical course of infection. On average, the incubation period is 5 to 6 days, but it can be up to 14 days. Now, since then, through international experience, we've learned that persons can be symptomatic 2, possibly up to 3 days prior to them developing symptoms. So we know the measures to prevent the spread of the disease. Good hygiene, hand washing, sanitizing, cough etiquette into your elbow, cleaning the services, suspending any events with crowds, physical distancing, wearing of masks, intensive contact tracing to identify cases, quarantine, isolation, and of course, making sure that health providers have the personal protective equipment. And just like in Wuhan, total lockdown when needed. The transmission dynamics of the virus, we are still learning about it. It's primarily person-to-person spread, and spread is usually from persons with symptoms. But we are seeing now that people with minimum symptoms or pre-symptomatic, so they have not developed symptoms yet, these persons can transmit, and of course from touching contaminated surfaces, because the virus can live on surfaces from 2 hours up to as much as 3 days. Now, there are many lessons. I've emphasized those from China. There are many lessons from different countries. I'm going to touch on South Korea. South Korea had the experience of dealing with SARS about 15 years earlier. So they had been through that kind of epidemic. And they had early recognition and moved very proactively, fast, before it became a crisis. They tested early, often, and safely. They did contact tracing, isolation, and surveillance. They used technology. They used cell phones to help them with contact tracing and alerting persons who may be at risk because they were exposed to someone who was found out to test positive and had the infection. They enlisted the public's help. They controlled their borders and tested people coming in. And of course, they reassured and educated the people while fighting misinformation. Now, there's a story about 2 towns in North Italy. One of the towns was called Vo, and they tested all 3,300 inhabitants. Now, I'm not giving you the exact numbers, but approximately 100 tested positive, 3% of the population. And they found that of these 100, 50 of them were asymptomatic. So the early testing and action to quarantine and isolate helped to control the spread in Vaud. In another town in North Italy, where there was minimal testing, it resulted in significantly more cases. So the importance for us of aggressive testing, we must test all suspected cases, all close contacts, whether the contacts, once they're close, whether they're symptomatic or they are asymptomatic, they need to be tested. All patients with pneumonia, persons who have any of the symptoms that could be consistent with COVID, influenza-like symptoms, these people need to be tested. And of course, frontline workers. And then the final message is the importance of international solidarity. And the WHO report in China made the point that true solidarity and collaboration among nations is essential to combat the common threat of COVID. Information has to be shared rapidly. Now, the World Health Organization sounded the alert early and advised countries repeatedly to act. The WHO has provided a whole range of superb technical advice, resources. In Jamaica, we got our initial testing kits through the help of PAHO and WHO, and they've been doing this internationally. Countries must act to support each other and one another. We have to share the lessons that we can learn from controlling and containing COVID and ensure that all countries benefit from the technology, tests, and any new treatment and vaccine that is developed. Now, just a couple other examples of solidarity. We were able to get help from Cuba with nurses and doctors, ICU nurses. A team of doctors from Cuba went to Italy to help them when they were under stress. There was a millionaire in Asia who sent supplies over to Latin America, South America, to help countries there. So it is important that we recognize that we're all in this together. And those of you who have seen the scenes in Italy when people come out in the evening and together sing, and throughout the world, in the United States, in Italy, in Europe, in other countries, people come together at particular points to pay tribute to the frontline workers, the healthcare providers. But it's not just healthcare providers who are on the front line, all the frontline workers, to offer solidarity to them because they are taking the brunt of the response, and we all need to support them. Thank you.
Thank you very much, Professor Figueroa. I like the point that you make that we're really in this together, and this is a pandemic, and by the very nature that it affects all countries worldwide, that we can share and learn from these experiences. I recall the governor of New York talking about one state helping another with ventilators because it's moving at different phases. So as you no longer need your ventilators, maybe another place can use it. So I think that's the philosophy that you're sharing here. So certainly I think the question about testing comes up again. Now, it was raised before by Professor Celia Christie and Dr. Joshua Nzinga, and you quote the story of the town or the city of Vaud in Italy. And perhaps I can ask you, in the context of given the cost of testing, Dr. Nzinga shared with us this morning that molecular type tests are very expensive. If I hear the success story of Vaud that you're presenting, there seems to be a case where you say if we test early and we test everyone, that there's some benefit in understanding the nature of the epidemic in that particular setting, and we can take action to follow. Are we at a point where we can talk about cost effectiveness of such a strategy, given the kinds of tests we have in the market and the call for a public health approach that may say early and wide testing is of value? Could you say something about that, vis-a-vis, cost and effectiveness?
Yes, I think this is a very important question. And at this point, the tests are quite expensive. They're labor intensive. It takes us at least about 8 hours currently to do this test in Jamaica. And if you do it from the time when the swab is taken, getting to the lab, and then done, sometimes it's 24 hours before you get the result. In Wuhan, in China, after several weeks of doing this, they managed to get the testing time down to 4 hours. Now, what I am hoping is that given the technology, and many companies in the United States, Europe, China, and in Asia, that they're going to be developing tests that will become less expensive, they'll become more rapid, and these kind of tests will help us to do, hopefully, point-of-care testing. In China, they used to get the person to wait on the result before sending them home, so they didn't send home anyone who was positive. Now, if we have to do our best with testing, with what we have, hopefully we'll get more rapid tests. But there's another approach that we can take, which will help in part. And that is, we can use a clinical definition, case definition. So anyone who has symptoms that are suggestive of COVID, let us act as if that person is positive, so they can self-isolate at home, wear a mask, ensure that household persons are not in close contact with them, although they are supporting them. And we can use this clinical case definition so that people take precautions up front. Also, because we know people could be infected before they develop symptoms or even are asymptomatic, when we are in public, we should behave as if we are infected. And therefore, it would be better to maintain the social distancing. Once you go into a crowded place, public transport, put on a mask, hand wash, sanitize regularly. So we have to adapt to our resources and situation to deal with it, even while we await and hope for less expensive, rapid technologies to support us.
Thanks very much, Prof. I think the word too, in terms of the success, and you spoke about China and Wuhan and the aggressive response that occurred in terms of their success. I hear discipline coming forward, the need to be disciplined, be aggressive, but ready to take action if you suspect you're wearing your mask, the distancing, and keeping that in place. Prof. Figueroa, thank you very much for your excellent presentation and for giving us hope. Prof. Abel will share with us later on in the conference hope, but you've already shown some signs that there can be success and that there's perhaps more success down the road coming for us in our response to COVID-19. Thank you very much, Prof. As we talk of COVID-19 and social distancing, we must not lose sight that the cause of all of this, all of what we're seeing and feeling and all the activity is actually a microscopic germ that we can't see with the naked eyes. We need sophisticated microscopes to see it and analyze it and understand it. And I'm really happy that we have within our university, within our faculty, we have persons who are specially trained and have that expertise, virologists. We have today with us this morning Dr. Sandra Jackson, who is a lecturer in the Department of Microbiology in the section of virology here at the University of the West Indies, Jamaica. And Dr. Jackson is going to share with us the behavior of the SARS-CoV-2 virus from Wuhan to Jamaica. So we want to look at how this virus has behaved since the December 2019 discovery to current period. Is it the same virus? Anything different about it? So we're very happy to welcome Dr. Sandra Jackson. She'll join us remotely as she speaks on the behavior of the coronavirus 2, from Wuhan to Jamaica. Let's welcome her.
Good afternoon, Dean Paul. Thank you for inviting me to speak on the behavior of SARS-CoV-2 from Wuhan to Jamaica. The objectives of today's presentation will be to review the countries which will most likely impact the continued introduction and spread of SARS-CoV-2 strains in Jamaica, the timeline of related events, and the relative risk of importation of SARS-CoV-2, and how molecular epidemiology can support a better understanding of the geographic spread of the virus. Other factors affecting the spread of SARS-CoV-2 will also be addressed. During 2020, countries worldwide have been dominated with the emergence and management of COVID-19. Thousands of persons have now lost their lives. Many are infected, and major cities are on lockdown with economic crisis looming. How did we arrive at this situation? And what caused this novel COVID-19 to spread so quickly globally? It was early in December 2019 that is in the city of Wuhan that China had reported several cases of atypical pneumonia of a known cause, which were first linked to the seafood market in Wuhan. WHO was informed on the 31st of December, and China implemented procedures to ramp up investigations and to investigate the spread of this unknown virus strain. By the 2nd of January and reported on the 3rd of January, China had identified the strain to be a new coronavirus, termed novel coronavirus. Soon it will be renamed to be called SARS-CoV-2, and it causes the disease COVID-19. It was so named because it was closely related to its predecessor SARS coronavirus, which had emerged 17 years ago. At the time when SARS had emerged in 2003, however, it was able to be contained and it did not cause a pandemic. This virus, although it was similar to the SARS of 2003, did, however, have some differences. By the 9th of January, China reported its first death. However, at this time, there was still no evidence of human-to-human transmission. And at this time, major mitigating procedures were put in place, and the country was put on lockdown. Irrespective of this, with New Year celebrations, certain percentage of the population was still able to travel to and from China prior to the final closure or lockdown of Wuhan city. Thailand on the 13th of January reported their first case of SARS-CoV-2, and on the 16th of January, outside of China, Japan reported the importation of the virus. The number of cases in China continued to increase significantly, and China proceeded to build a 1,000-bed hospital within 10 days. By the 20th of January, South Korea and the United States also reported imported cases of SARS-CoV-2, and at this time, there was increased evidence of human-to-human transmission. Other countries that followed subsequently in reporting the detection and importation of SARS-CoV-2 included Taiwan, Hong Kong, Singapore, Vietnam, France, Nepal, and on the 25th of January, Canada also reported imported cases, and particularly associated with long-term care facilities. By the 31st of January, the United Kingdom had reported new cases of the coronavirus. On the 30th of January, WHO declared a public health emergency for the novel coronavirus. And the first death outside of China occurred on the 2nd of February in the Philippines, followed by the second official death outside of China reported in Hong Kong on the 4th of February. On the 10th of March, Jamaica confirmed the importation of its first case of the novel coronavirus. WHO announced COVID-19 outbreak a pandemic on the 12th of March. At this time, 20,000 cases had been confirmed, with approximately 1,000 deaths in the European region. As it stands now, as of April, the 17th of April, globally there were 2.2 million cases reported, with 153,818 deaths in 210 countries. In Jamaica, as of the 17th of April, 143 cases and 5 deaths had been reported. When we look at this graph, we will see, looking at the purple arrow, it's actually indicating the detection of coronavirus in Jamaica by the National Influenza Center. The red line indicates the percent positivity of influenza viruses. So we can see here that the percent positivity of coronavirus is far more than that of influenza at this time. Also of significance is that the number of SARI hospitalizations in epidemiological week 14 has also crossed the threshold, the moderate threshold level. So let us talk a little bit about the relative risk. And to review the relative risk associated with countries that are presently having major outbreaks of the coronavirus, what we could do is look at the EpiRisk platform, modeling platform that they have. And this platform actually uses each location, the location of the country on the y-axis, and the probability P that a single infected individual is traveling from the index area to a specific destination Y, which would be Jamaica. So when we look at the United Kingdom, because we do have a significant amount of Jamaicans in the United Kingdom and also visitors from the United Kingdom. And in addition, the first cases in Jamaica were actually from the United Kingdom. The relative risk of importing cases from the United Kingdom here is calculated as 0.09%. From the USA, the relative risk is 1.89%. From Canada, 1.57%. From the Bahamas, 0.98%. From Barbados, 0.98%. I think from Guyana, 1.14%, 1.44%. I think we missed Trinidad here. And from Trinidad and Tobago, 1.83%. Reviewing the relative risk can guide us and guide Jamaica as to what to expect, which countries we would most likely expect the possibility of continued importation of COVID-19 cases. Let us look at the phylogeny. The phylogenetic tree of the coronaviruses with representatives from each of the 4 genera include the alpha, beta, delta, and gamma coronaviruses. What we want to focus on is the beta, the genera that's looking at the beta coronaviruses, and this is the where the SARS-CoV-2 and SARS that caused the 2003 outbreak belong to this group. The beta coronaviruses are further subdivided into 4 lineages termed A, B, C, and D. The C in orange lineage, and the B in green. The phylogeny shows the evolutionary relationship of the human coronavirus, or SARS-CoV-2, from the ongoing novel coronavirus pandemic. And the phylogeny will show the initial emergence of in Wuhan, China, followed by sustained human-to-human transmission, leading to sampled infections. Although the genetic relationships among sampled viruses are quite clear, there is considerable uncertainty around the estimates of specific transmission dates. And in reconstituting the geographic spread, this needs to be taken into consideration. Therefore, specific inferred transmission patterns are only a hypothesis. The phylogeny, what we will look at is the data is taken from analysis via NextStrain, which actually uses information uploaded to the GISAID platform. And looking at this transmission breakdown, we can see that within the beta coronaviruses group, that there's further subclassifications into clades. And when we look at the viruses in China, emerging from China, we can see that that they're mixed. When we look at global sampling and we look at the epidemiology, we see that most of the clades globally, according to this analysis, belong to the A clade. Within the USA, we can see again that it's in North America, and referring particularly to the USA, we have a predominance again here of the A clade, both here and Canada. Again, we see A, predominance of A circulating. And in the United Kingdom, A again. We have at the 2 extremes, we have both the A1A and also the A2A being identified in the United Kingdom. So the lineage B can be divided into functionally distinct clades, some of which exhibit compatibility with receptors on human cells and some which are unknown. These clades are capable of recombining to impact human host cell entry phenotypes. Beyond the RDB receptor interaction, host proteases processing is another species barrier encountered by the lineage B beta coronaviruses during cell entry. Looking at the global picture of where we are today, we can see, just observing from the color scheme, that there's a predominance of the A clade of the beta coronaviruses here. And we see, although A is predominantly found, that there's some heterogeneity here, we also have imputation and also continued proliferation of some of the B clades, not just only in China here, but we detect some of them have been detected in the North America. So enough genetic variation between different strains of viruses that is there to place them in clusters or clades. Within the clades, there continues to be genetic variation, resulting in further subdivision of those clades. Research on the implications of such diversity is ongoing, and several studies have been published, and continued research and outputs are needed for better interpretation of transmission and clinical implications. Sequencing data being presented may have implications for vaccine development and treatment. What other factors have been proposed to be associated with the geographic spread? We look at things like weather. The Global Virus Network, which constitutes 52 research centers worldwide, has been supporting such initiatives on weather modeling. And this will help to explain the spread of the virus and possibly to predict the regions most likely to be at higher risk of significant community spread of COVID. The color gradient indicates temperatures in degrees Celsius. And if we look here, the risk of significant community spread here is demonstrated in the light green bands outlined by the darker bands. And as the weather changes, as we go through the different seasons, let us see what will happen as we transition from the winter to spring and to the summer months. And this will also help to determine how the virus will behave on an ongoing basis. So in summary, there are several factors that influence the geographic spread and human-to-human transmission of the virus. There are host factors, including underlying disease, immunity, and things such as the D3 deficiency, which is also associated with the sun's rays and the weathers in different zones, climate zones. Virus factors, the virulence, the pathogenesis, asymptomatic infections, environmental factors, including transport, locally, internationally, and climate, social factors, economic factors, importantly, the capacity of the medical system to detect, respond, and contain the virus, and the understanding of the community and healthcare workers of the virus and risk factors that are associated. In interpreting models for projections, the interplay of all these factors need to be considered. Countries such as Jamaica, in preparing for the detection of further imported and community spread, should use all available resources and information and mitigating strategies to contain the continued spread of COVID-19 and minimize morbidity and mortality associated. Thank you very much.
I want to thank Dr. Sandra Jackson for her presentation. You can hear, if you listen, ladies and gentlemen, at the content here, you hear the detail. This is a really small microscopic particle, as I call it, the virus. But Dr. Jackson has provided such detailed information on its behavior. And it's, she talks about mutation and those kind of things. Certainly giving us very, very important insights into how the virus is behaving and how things have moved from Wuhan to Kingston, Jamaica. I think this information is important as we battle it on all fronts, as we take the fight out there to the COVID-19 pandemic. So once again, thank you, Dr. Sandra Jackson, for taking the time to put this excellent presentation together and to present to us on the behavior of this virus here. Thank you very much. While COVID-19 is a disease that affects really everyone, we heard from our former speakers that we're all at risk. It has a worse effect on our older population, members of the aging population. And certainly also we have seen persons with pre-existing conditions. That term, there are a lot of phrases and terms we are learning as this COVID-19 goes forward. We hear about pre-existing conditions. And so today, ladies and gentlemen, this morning, I'm very happy to introduce one of my distinguished colleagues, Professor Denise Eldermeyer-Scherer, who is going to bring insights to us on this issue of the impact of COVID-19 on the older population, on seniors, and that's almost all of us now. I think I will qualify in that group. So I'm very eager to hear what she has to say. And also on the issue of pre-existing conditions. Professor Eldermeyer-Scherer is well known in the region at the University of the West Indies. She is Professor of Public Health, Aging and Public Health. She's also the director of the Mona Aging and Wellness Center and a former head of the Department of Community Health and Psychiatry. And she wears many hats. It will take the whole morning for me to give all of the full introduction for this distinguished lady. But certainly, ladies and gentlemen, it's my pleasure to welcome to the podium our Professor Denise Eldermeyer-Scherer to speak on protecting the vulnerable seniors and the pre-existing conditions. Professor Scherer.
Thank you very much, Dr. Paul. Let me add my word of congratulations to you, to Prof. Christie, for pulling this together, and of course for including the older persons in it. You mentioned the issue around seniors. Now, seniors are only 12%, 13% of the population across the Caribbean. However, we are taking our messages from what we have seen happen in particularly China and Italy, where the information is available from. And if the current slide speaks to that, and it tells its own story, in that you look at the death rate in the 80-year-old versus the 50 to 59, and you see the dramatic increase in that older age group, 80 and over. There has been emphasis more recently on the 70 and over, and with just cause, because as you can see, that's 8% in that age group, 70 to 79, that was kind of getting buried. Hence, whereas we started off talking about over 80, and you will notice that the initial regulations here or directions actually said 75, and in the government's last go round of regulations, it changed to 70, and there is scientific evidence for that. They speak about pre-existing conditions, we speak about comorbidities. Again, we had started off talking about diabetes and hypertension, which are still very critical, both of them, as you can see from this slide, being 9.2 and 8.4. But you will remember that there was a case here in Jamaica that they wondered if it was COVID or heart disease. And we are now finding, and this is WHO CDC information, cardiovascular disease is in fact the comorbidity most associated with death rates at 13.2%, and is significantly higher than the other three individually. And therefore the issue around MIs, etc., is very important. Raises an important point that I want to make on this slide. We have to be very careful about the focus on COVID-19 when it comes to older people, because with the high rate of comorbidities, we are still seeing the heart attacks, we are still seeing the illnesses that we see in the older person, and we have to be sure that they don't get buried under the COVID-19 initiatives. So COVID-19 is killing 13.4% of patients over 80, compared to only 1.25% in their 50s and 0.3% in the 40s. Therefore, this speaks to the importance of trying to protect. And we now know something we didn't know 4 weeks ago, and as everybody says, this is very evolving. As we get more and more cases, unfortunately, we get more and more information. The sharp divide is at age 70. It's 4% of people in the 60s, doubling for the 70s. So we begin to see that it's 70 and over where we need to focus. And I found the next one, got it yesterday, interesting. In Italy, of the persons dying, 83% of them were over 60. So there's no doubt about it. So why are older people so vulnerable? Aging in itself causes an increased risk, and I'll show you why, than the earlier years. And they're not able to fight the virus as well because the older immune systems are weaker, the wear and tear of time. What is happening is that each time your body has to fight something, it takes its toll on the immune system, coupled with the aging changes of less cells, etc. And therefore, by the time you get to 70 and 80, the system is simply not as responsive as it was before. It also, aging itself, slows down the body's responses. To the reaction time actually decreases. That's wrong. So, sorry, increases is correct. So you take that much longer. Just think of somebody that you are speaking to and the pause before they answer you. That takes place throughout the body. So when you speak to the immune system and you say, I'm on board, I'm a virus, it takes a while for the immune system to respond. And thirdly, the low-grade inflammation that many older people have constantly due to arthritis, and we have, 42% that report arthritis, that dulls the ability to respond. It's a bit like, you're constantly, the analogy that was given is, something's buzzing in the air. Eventually you stop hearing it. Somebody coming into the room hears it. Well, your system is no different. So how do older persons and the wider society, including family and friends, and here we say governments as well, protect older persons? There's really only one option: don't get it. That's the best option for older people. Part of the challenge is, how do we get older people to understand you simply cannot get this thing or you're going to pay the price? So we need to protect older people. How do we protect older people? We start with all of the guidelines on sanitizing and washing hands, and as has been distributed. Sometimes challenging, especially in communities where there is no water. And I will mention the social distancing and what happens in high density communities. So you follow all of those guidelines, regardless of whether you're staying at home or not, regardless whether you're avoiding all contact. You still have to do the sanitizing. You still have to cough into the tissue and throw away the tissue. Now, we know a lot of older people use a rag and use a towel. That does not work during COVID, because you're going to reuse that rag and you are going to reinfect. So it's about tissues, paper towel. I know it's a cost factor, but it's a cost factor that might save your life. So older people do this by staying home and avoiding close contact. I don't like the term social distancing, because social distancing in older people leads to social isolation. And therefore, we prefer physical distancing for older people to get across the point that, yes, you need some social interaction. And unfortunately, this does include family and friends. So the grandchild climbing all over you has to be from a distance. The grandchild can come into the room, but you and your children are going to have to learn to communicate from at least 6 foot apart. It's not ageism, it's not discrimination. I keep hearing that it's a penalty. Some say that this is just too much. But honestly, it's probably one of the first times that so many people have wanted to protect our older people so well. And we really need to take it as a blessing and say that we are at least being recognized as an important group. So it's not, it's care, it's love. So social isolation is a real concern for older people. Older people are already combating loneliness. One little interaction is to go to church. One only has to look at a churchyard after the service is finished and people are hanging around for an hour or two talking. Going to the supermarket, as one lady told us on the radio the other day, and she was, 85, nobody can pick my meat for me. Nobody knows whether the pink is the right pink or not. We suggested to that lady that she have her son, who is doing her shopping, send her the picture. She does have a smartphone. So we suggested he could send her 4 or 5 pictures. She could tell him which one. To which she said, but I haven't touched it. So it's really about behavior change, and it's really about adjusting your life, bearing in mind you want life. So you don't want to put yourself in harm's way. Also, interaction with people for older people is all about self-worth. It's about feeling wanted. It's about feeling needed. That caring for the grandchildren. So many of our older people are really missing the school pickup because that's when they interacted. That's when they felt important, when somebody would say, please pick up Johnny at school. And therefore, as we look to the social isolation, we need to find ways that older people can still consider themselves important and worthwhile. It means no hugging. No hugging does not mean no contact. And I think that's an important message. Communication and staying in touch is therefore key. And how do you do this? And here families have a key role because we've gotten used to saying, well, okay, 80% of our older people are fine. They're physically and mentally well. And that comes from the 2012 study of older people. We actually only have 8% dependent. So most older people have gotten used to making life for themselves. And we're now taking that away from them. So we need to make the suggestions as to what else. Church is a big thing. So find church on radio and TV. They may not, and this is family again, have a critical role. So family is going to have to step into this gap. Family, of course, here does not mean biological only. Many of our older person has the person next door, the neighbor next door, who is the real family, the 24-hour family. So family here is your community family, your church family. Someone can come, yes, they can come, because if they sanitize and they put on their gloves, they can find out where on which channel, because most of us with 700 channels haven't a clue where to go. So one of the gifts that you can give an older person is to go and find their church service for them and show them which channel and how to get there. Market. Where on radio? We have so many radio stations now. The younger people can find out which church service is going on, who is doing what. Is it Reverend Blair? Is it somebody else? Who is the sermon for Sunday? And I warn you, older people do not think it's church without singing. And they say they have to hear this song. So you have to get a real church service. One of the keys to successful aging is having a routine. Now, most older persons' routine has been dislocated by this social isolation. They are used to going to the supermarket on a Thursday. They're used to going to church on a Sunday. They're used to going to the pharmacy. By the way, pharmacy and doctor is an outing. It's not just, we're saying get a relative to pick up. We are removing an hour of social interaction. So they need to have a routine. So it's for a family member to sit and figure out what is the routine for the next 4 to 6 weeks, and a routine which has some interaction. Maybe it's doing homework via the telephone with a grandchild, and have a plan. A plan for this routine, but also, most importantly, a plan if you get sick. What is the plan? Everybody is being told stay at home, but an older person needs to discuss with somebody. We had a case yesterday where an older person, diabetic, hypertensive, couldn't get up. So we were talking about it. It turns out this morning the person does have to go to hospital. The glucose monitor was not working. So whereas the wife thought it was 48, it was 480. So that you have to be available. Healthcare has to be available, and a temperature of 102 in the axilla, and they don't have COVID. They haven't been out of the room. So the thing is that you have to have a plan. Who will you call? Don't think I'm old, there's no room for me here. Tell somebody if you don't feel well. Equally, reach out to family and friends to discuss your fears. Information is power. A lot of people are hearing about COVID, a lot are watching the television programs, and they're not sure about it. Discuss it, share ideas. There is an important group of people. There are about 40 to 50,000 of them, and a group that have real issues when it comes to COVID. They have difficulty understanding all this information and facts. What they know is that their life has turned upside down. They used to walk outside, suddenly you're telling them to stay at home. One patient that I have has very agitated because her daughter is at home. If her daughter at home means her daughter lost her job. Her daughter at home does not mean that she's asthmatic and has to be at home. She's lost her job. And she, the mother, is now a burden because with no money, how is she going to look after her? She does not understand COVID. So they're going to have difficulty. They may even have difficulty remembering and understanding the safeguarding procedures. One lady wanted to know why she must wash her hands. Are you trying to tell me I'm dirty? You don't tell me to wash my hands before. And why do you have on a mask? Are you scorning me? That's the world of somebody with dementia. So let us remember these people. They're certainly going to ignore the warnings. They're not going to self-quarantine and they're not going to isolate. And families are going to get very frustrated because you're telling this person to stay inside and they're going outside. And then there are the caregiver issues. There are many caregivers today who cannot come out of St. Catherine. There are many caregivers that are coming out of areas and the family wants to know how to test them because they're coming out. I was talking to one who's coming from Spanish Town. So we have said do temperatures because they can't get tested. The mother in this case has a peg tube. So she is at risk. Can the caregiver come? Persons in the rural areas have a benefit here because rural areas, even with crowded houses, the caregiver can usually stay in. And then there's the possible clinical issues. Is it confusion of dementia or is it confusion of fever? Remember, older people don't get fevers, they get confused. Close family members know the different types of confusion. Trust me on that one. They know, they have been through this for years. Many of them know the difference between the confusion of the dementia and the confusion because the sugar is too high. They know the confusion of a fever, of an infection. Listen to family members. Do not get caught up in the pressure of COVID and lose an older person because of not listening and not checking them. The delirium of hypoxia can present very similar to dementia. Which is it? Is there COVID or is there not? We are saying stay at home. We are saying stay away from people. But we also now know that a large number of persons who are asymptomatic can spread the disease. So therefore, we need to protect our older people, even those that are at home. And memory issues, so they can't give you a history. They don't know where they went. And this is all came out in Lancet this month. So that is how some thoughts on protecting our older people so they can live to see tomorrow. Thank you.
Thanks very much, Professor Eldamar-Scherer, for, wow, I was just, I don't know if it's breathless, but I was taken up by your presentation as you sort of unravel the social fabric of COVID-19 in the context of the aging population. I think, ladies and gentlemen, it was a kind of reality check for us, some really, really pertinent issues that face us every day. I think I want to ask Prof a question, and we've seen in the news in some settings that, and based on your report there, the nursing homes in all parts of the world, not only the Caribbean, we have a large number of nursing home settings set up in different levels and different set of technology and so. But it's a place where we find a lot of our seniors living and, having a community life. What can we do to reduce risk in nursing homes? And how do we, some people say, should I put my mommy in a nursing home at this time? Is she safer there? So could you say something about that, Professor Sherrill?
Thank you very much, Dean Paul. I knew there was a second group that I was to put up there with the dementia, the nursing homes. Very important and very concerning. And there are two issues to the nursing home issue. We're also saying family shouldn't visit. So an older person, even not necessarily with dementia, but doesn't know why you're not coming. You will have seen that some of the nursing homes in America have allowed you to look through the window and to have conversations. But most of the nursing homes that I have been to here, both public and private, are kind of closed in. There's no sort of outside window. But thinking on my feet, one of the things that could be done for some of them is many of them do have verandas. So for well older people, you could bring them to the veranda and socially distance. So you could, exactly. You have to be very, very stringent with the staff. Temperatures need to be done going in every morning and at shift changes. They have to wear masks, and they have to use gloves. So it means that we have to think about PPE for local government staff, for the public infirmaries, and everybody knows that they're a special interest area, as well as the nursing homes. So, and these fall not only under the Ministry of Health, because homes for the elderly are not nursing homes and are governed by the local government regulations, because they're not sick. The washing of hands is critical. Not every nursing home has a basin in every room. And therefore the issue of making sure that every bed has a bottle of sanitizer beside it. And of course training of the staff. And I think we just have to, there's also a problem with the homes, both public and private now, with all of the various lockdowns. Nutrition is critical. One of the most important things about the immune system is that you want to support it. Nutrition supports it, exercise supports it. But on lockdown, you can't do exercise. They're not getting a lot of fruits and vegetables at the moment because they can't come in from the various places. So you want to look at that. But I think the most important thing is the staff. And the sanitizing is important, but also doing the temperature is important. And reassuring them. No, I would not put anybody new in a nursing home at this point of time. Not only because of COVID, but moving to a nursing home is a traumatic activity for an older person. So you don't want to have two traumas at the same time. So hold on and wait.
Thanks very much, Professor Eldamar Sherrill. I think as we thank Prof, one of the things that the hosting of this conference now from the Faculty of Medical Sciences, our UE campus in Jamaica, is, in addition to sharing information, to bring a sense of hope and to put some positive support and guidance for our population. And I think this presentation has brought what I would call a kind of collective empathy for the care of our seniors at this time. And certainly we see, I take from Prof's presentation, we all have a role to play, family, caregivers, government, public-private sector, as we move forward. So once again, thanks very much, Professor Eldamar Sherrill. Excellent presentation. And we'll move on to our next speaker on our COVID-19 pandemic conference. We're very happy that you can join us this morning on our COVID-19 pandemic approaching Code Red conference. Again, I want to welcome all of our audience out there, those of you who have joined us on the link. And as we continue on the conference this morning, we are looking at a broad picture. Our University of the West Indies, our Vice Chancellor, Professor Sir Hilary Beckles, takes a very broad look at where we are with respect to the situation. We have a UWI COVID task force set up and chaired by one of our pro-vice chancellors, Professor Landis. And I'm very happy now to welcome another one of our pro-vice chancellors, Ambassador Dr. Richard Bernal. Dr. Bernal is a professor of practice, Pro-Vice Chancellor for Global Affairs right here at the University of the West Indies, and he's written quite a lot in the areas of globalization, trade, economic development, and in fact he's heard on radio on Power 106 in Jamaica on Mondays at 11:30 a.m. speaking on the global economy. And so he's very well placed for him to speak on the topic post-COVID-19 pandemic economic outlook, an important aspect of our response to the pandemic. We have spoken a lot this morning about the health and the epidemiology, clinical testing, but the story is not over until we look at the impact of COVID-19 on the economy and on the wider community. So ladies and gentlemen, just join me in welcoming Ambassador Dr. Richard Bernal, Professor of Practice, who will address the topic, what happens after COVID-19, the pandemic economic outlook. Professor Bernal.
Thank you, Professor and Dean of the Faculty of Medicine. I'm very pleased to join you for this discussion of the impact of the COVID-19 pandemic. The pandemic, as you have mentioned, has already been discussed in terms of its health implications. And today what I want to do is to share some thoughts with you on the wider economic implications. The pandemic has already put national and global economies into a recession. Nobody's sure how long the recession will last and how intensive it will be. We've already seen a contraction of economic activity of significant levels. And if this persists, it will certainly be a recession of a magnitude worse than that which followed the 2008 financial crisis, and far worse than that which followed the September 11th terrorist attacks. Indeed, the more dystopian forecasts are talking about levels of unemployment which rival that of the Great Depression of the 1920s and 30s. What is sure is that the world economy and our economic and social life is never going to be exactly as it was prior to the pandemic. The pandemic has implications not only in the immediate future and the present, but some of the changes which will be initiated as a result of the impact of the pandemic are likely to be changes which will become medium and long-term structural and institutional changes as the effects of the pandemic works through the economy and as the recovery takes place. Because the Caribbean economies are small developing economies, they are highly vulnerable to external events. And in looking at the economic impact on the Caribbean region, I therefore want to divide my remarks into two sections. First of all, I want to look at the global economy and then turn to the implications and the indigenous aspects of the economic impact in our national economies. At the global level, a number of forecasts have been undertaken, and I will share with you what those are. The International Monetary Fund and the World Bank usually have meetings in April and October. And in the April meetings, they prepare a global economic outlook. Their forecast is that there has already been a significant loss in the first quarter of 2020, which will continue and perhaps intensify in the second quarter. They are basing their forecast on the assumption that in the third quarter and the final quarter of 2020, there will be some resurgence and recovery of economic activity. Indeed, in the first two quarters, the losses have been very significant. Measured by, say, unemployment in the US, already 22 million people have applied for relief. and the impact is across the globe in terms of loss of employment. It is felt that the overall rate of contraction will be somewhere between 3 and 5%, based on the assumption that losses in the first half, some recovery in the second half, and coming out at 3 to 5%. This, of course, is based on certain assumptions which may not materialize. Things may actually be worse, depending on the duration of the pandemic, how long it takes to bring the pandemic under control, and how much has to be spent to resuscitate employment and economic activity. Turning to the Caribbean economies themselves, the Inter-American Development Bank, World Bank, and IMF have all made some estimates of the likely impact of the COVID-19 virus pandemic on Caribbean economies. And I share these with you. First of all, it is forecast for Suriname, a contraction of 1%, in Jamaica, 2.9%, Dominica, 3%, St. Vincent, 4%, St. Lucia, 7.2%, and Barbados, 7.7% contraction. These are measured in terms of contraction of GDP, which, as you know, is a measure of overall economic activity. The estimates, unfortunately, have not been provided for Trinidad and Tobago and some of the other Caribbean countries, but I share with you what has been published in April this month by those institutions. I give you an overall view of the likely impact. Now, turning away from the macroeconomic impact to the sectoral aspects and to individual aspects of the impact. First of all, there is already and will continue to be a major impact in terms of fiscal budgets. The Caribbean economies were already experiencing difficult fiscal situations, and some countries were working out of very difficult debt situations, where the debt to GDP ratio in some countries is well over 70%, sometimes over 100%. There will be a major reallocation of expenditure to come as money is invested in public health, in controlling the pandemic, and in restoring the health of the population. In addition to that, the regular budget expenditure is not likely to take care of the issue of the expenditure for public health, and therefore there'll be need for additional revenue. Obviously, at this time, additional revenue cannot be extracted through tax because economic activity is down and a number of persons and businesses are suffering severe difficulty. So it is likely that there will have to be borrowing. The borrowing situation is going to be somewhat difficult. It's going to be somewhat difficult because the Caribbean economies are regarded as middle-income developing economies, and therefore they are already graduated, a polite term for excluded from the most concessionary financial facilities. However, there are some immediate disbursing facilities from the IMF. The IDB and World Bank have reallocated within their portfolios a significant amount of money to assist countries to make these transitions, and we will have to access those. Those countries where the local financial markets are such that they can borrow locally will also have to resort to this. But it will also mean that within this reallocation of resources to take care of the public health expenditures, that some cuts will have to be made in some other planned expenditures. Secondly, in terms of employment and unemployment, we are already seeing a number of persons who have been placed, in particular in the tourism industry, which is likely to take some time to recover, and in entertainment and services in general, but increasingly across all economic activity, because all these sectors are linked, and the decline in employment and income in one sector serves to contract demand across the entire economy. There is going to be some increase in unemployment. One of the factors that has to be noted is that much of the employment in the Caribbean is in the informal sector, and these people therefore depend on expenditure from households and businesses in the formal sector. Thirdly, I think it is reasonable to expect that across the globe, those who are already disadvantaged and poor are going to feel the effects disproportionately, and in the short run, there will be an increase in poverty and inequality. Fourthly, the debt situation, which I referred to earlier, is going to be exacerbated in that there'll have to be a substantial increase in debt. Debt has to be paid for, and even if there's debt forgiveness, debt restructuring, refinancing, there is still going to be a lot of increase in debt, given that the Caribbean countries were already among the most heavily indebted countries in the world. A fifth impact is going to be some adjustment in the role of the state. The kind of resuscitation of the economy which will be necessary is going to draw the state into an expanded role. In addition, whenever there is a crisis, scarcity of supplies such as certain medical supplies, you are going to have the intervention of the state to bring more regulation to the operation of the market. The market left by itself may allocate those scarce resources only to those who are already relatively well off. A sixth thing is that globally, there's going to be a pushback against globalization and a repatriation of a lot of manufacturing and agricultural production, which previously was imported. Countries are now going to realize that the cheapness or the availability of imports is not the only consideration, and that domestic production also is important for the security and the resilience of their economies. So some of that premature deindustrialization which has been taking place in the Caribbean is going to be halted as we reshore, bring back on shore some economic activities which were relinquished, and this is good. Seventh, there are going to be opportunities in any crisis. The famous dictum is, a crisis is a terrible thing to waste. Put more simply, there are opportunities even in the midst of a crisis, and we must look for those. We have already seen a number of innovative developments, entrepreneurial activities at the household level, at the level of firms who have redeployed or redacted their production facilities to produce different goods, etc. So all is not doom and gloom. The Caribbean people have a long record of resilience to all kinds of man-made and natural disasters, and there's no reason why we should not find creative ways to expand. Finally, let me say that we are going to have to reactivate some sectors, and the extent to which we can reactivate those sectors depends not only on the measures we take internally, but it depends on how the global economy evolves and how quickly it recovers. In particular, I'm thinking that many of the economies are service-driven, tourism in particular, financial services, entertainment, BPO, business processing, outsourcing. These are good jobs, and they have served the economies in the region well. They will have to be resuscitated. This is going to require government to support the private sector in rebuilding, because there are expenses which the private sector must meet and households must meet, rent, etc., while the contraction of the economy is going on. The government will have to assist in terms of loans. The local financial sector will have to find ways to refinance and to alleviate some of the interest payment burdens which will be faced. And this is going to take a lot of collaboration across the society. It's going to have to involve a tripartite effort: governments, private sector, trade unions, civil society, to come up with programs which can resuscitate the economy. I remain convinced that the Caribbean people can deal successfully with this terrible pandemic. It is going to be difficult, but I see no reason why we should not be able to rebuild our economies. I end on the cautionary note that while we rebuild our economies, we must realize that life is never going to be exactly as it was before, and certainly the global economy will experience some changes, and we have to adjust to those in a proactive, strategic way so that we can resuscitate the economic development of the region. Thank you.
Thanks very much, Ambassador Bernal.
I think I went 16 minutes.
Thank you very much. You did very well. And we are very, I think that was an excellent and very clear outlook in terms of giving us that view, something that I think our audience would very much appreciate. Within your presentation, there's a lot of reality checks as to where things are, and those impact points that you raised in potential for increase in poverty, inequality being exacerbated, increase in debt, and coming with that, looking at the role of the state and so on. Ambassador, I have two quick questions for you. One is, some people paint, and maybe in an effort to keep hope alive, that tourism is not dead and that tourism can certainly bounce back very quickly. But in the context that what the impact on tourism is driven by a medical condition that carries stigma, and the issue of our tourists wanting to come back quickly and easily to countries, to our region, where, like many other parts of the world, COVID has come through. Is the outlook for tourism really optimistic, or is it, if we're doing a reality check, it's going to be a long, long time before we get back to where we were with tourism? What are your thoughts on that?
Let me put the recovery of tourism in context. First of all, international travel is going to be different than it was in the past. There will be a lot less business travel as more meetings will be done by Zoom. There will also be more health precautions. That is, I think airlines are going to be required to ensure that the passengers they take on board are cleared medically. If not, they will be responsible in the same way that if they bring into a country somebody who does not have a passport, they're responsible to take them out. That is going to happen. Secondly, the irony is that the developing countries of the Caribbean have done relatively well compared to some of the source countries for our main tourists, such as in the US and in the UK and Italy and Spain, so that people in those countries should feel relatively safe coming back to the Caribbean. Thirdly, based on experience after the global financial crisis and the 9/11 events, the Caribbean is close to the US. The pattern of US tourists is to take short visits. The Caribbean is affordable. It is doing well in terms of handling the pandemic. And I think that based on that, we could be favorably disposed for a relatively quick resumption of trips to the region. Now, I think that where tourism will be relatively soft for some time will be in cruise shipping. Cruise shipping had experienced various health crises even before the pandemic, and the pandemic has certainly trapped a number of people on board ships for extended periods.
Yes.
And I think it will take some time to rebuild the comfort level for people to start doing cruise shipping.
Yes.
However, the tourist industry has proven to be very agile and creative, and I'm sure that special packages in terms of price, etc., will be offered across the region in hotels and in the cruise shipping area. So all in all, I think that the tourist industry may be able to recover relatively quickly.
Yes, thank you. So that's very sound analysis. Professor Christie earlier in the conference had spoken about immunity certificates, the potential for things like that in the future. And as you mentioned, travel, airlines asking for perhaps some evidence that you're safe to travel. We can see things like that coming forward. My last question, perhaps just to get a comment from you. Prior to COVID-19, we recognized the presence of China in the Caribbean. And I know, Ambassador, you've written quite a bit on this. And we have within the university Confucius Center activities in terms of China being a partner within both the economy and the academy. Post-COVID, and given China's involvement with the pandemic, it started in Wuhan, we know, and now we see that they're catching their breath and picking up, while the U.S. is having quite a lot of challenges. Is there any kind of differential positioning that we would see with China post-COVID prior to where they were pre-COVID in the Caribbean region?
China has been an important source of development financing for the construction of infrastructure, buildings, etc. And as you know, the Chinese have launched a major initiative, the Belt and Road Initiative. Given the amount of financing that the Caribbean is going to need in the period of recovery, and given the fact that as middle-income countries, they are not eligible for certain dispensations. For example, the IMF debt relief for the 25 poorest countries includes Haiti, but it doesn't include any other Caribbean country. So I believe even with the additional resources which will be mobilized by the World Bank, IDB, Caribbean Development Bank, and IMF, that there will be the possibility of the Caribbean getting some development financing from China. This may very well be to improve the physical infrastructure in the public health sector, and also because these loans are usually available not at lower interest rates, but with less intrusive conditionality than some of the loan facilities available from the traditional multilateral development financing institutions.
Yes, thank you, sir. So I think, Ambassador Bernal, I want to thank you for putting the perspective forward. You said a good crisis should not be wasted. Charles Dickens speaks of the worst of times and the best of times. And I think you have our efforts in this pandemic conference here is to bring some hope. Certainly, your talk has you've been realistic, but within it I hear there's opportunity and there's hope for the region as we go post-COVID pandemic. Thank you very much, Ambassador, for your presentation, and we're very glad that you can join us. Yeah, thank you, sir.
Thank you.
Ladies and gentlemen, as we come to the end of this morning's conference, we want to look in a very heartfelt way at where we are. We have looked at where we are epidemiologically, in terms of testing, clinical science, treatment, therapy. But we want to get really at what I call the heart and soul of the COVID-19 response. The people or population, we. How do we feel? We talk about things like social distancing and the impact that is having on us. So as we move into Code Red, and as we approach Code Red, we want to look at hope in uncertain times and talk about where we are and what about us. And there's no better person that I know to present this topic. He was a speaker in our first COVID-19 pandemic preparedness conference, and I must say we had a lot of positive feedback on his talk. No other than Professor Wendell Abel. Professor Abel is currently the head of the Department of Community Health and Psychiatry here at the University of the West Indies in Jamaica. He's also a member of the UWI Regional Task Force on COVID-19, and he's professor of mental health, and he's well known in Jamaica and in the region for his work, his public service, and his work in promoting positive mental health. And that's why we have him here this morning, ladies and gentlemen. Let's welcome Professor Wendell Abel to really close us off on this, at this conference here this morning. Welcome, Prof.
Hello, everybody. Today, I'm going to be talking to the topic, hope in uncertain times. It was almost a month ago that we hosted the UWI conference on COVID pandemic. And it's almost 4 weeks later. And I want to pose a question to us. How has your life changed? And wherever you are today, I want you to just quickly write it down. Without thinking, just make a list of the changes that have occurred in your life. You can keep doing it, yes? You have a few seconds left. Okay. And I can only imagine some of the experiences we're sharing and some of the things that either come to your mind or you would have written down would include lockdown, for some persons, unfortunately, job loss, layoff, school closure, children at home, the financial problems, talk of economic recession. Sadly, for some persons, it's about illness and death. Hopefully for most of us, it's about social distancing and just being able to practice it. And for all of us, certainly our social lives have become limited. And the way we work and even the way we worship would have changed. These are indeed uncertain and frightening times. Uncertain and frightening times. But I want us to be positive and to remain positive. And to remind ourselves that although many persons will get COVID-19, it will be in a mild form, hopefully. And I'm sure this would have been shared with us by previous speakers. We also know that social distancing reduces the number of persons getting it at once. And the good news is the majority of persons who get the disease will survive. And I've shared this before, but I just want to share it again, that the death rate, and it's over range now and it changes, but approximately 99% of persons who get COVID-19 survive. And therein lies the hope, right? Only 1% die, and we hope we're not among the 1%. What about us? And so we encourage us to be positive, stop the catastrophic thinking. And I've been sharing this with us, shared it with us before, and to remind ourselves that we're not in this alone. We're all in this together. And you know something? We will all get through this together. And I think that therein lies the consolation and therein lies the hope. But despite my trying to generate hope and being positive, for many persons, many persons actually go through an emotional roller coaster, what I refer to as a COVID emotional roller coaster. And for those of us who've been on a roller coaster, we know what the feelings are like, right? And so I want us to name your feelings. I have projected here a list of feelings. And as I go along, check them if you're experiencing these feelings. Many persons, it's fear. Other persons, anxiety. Other persons, disbelief. In fact, sometimes I wake up and I ask myself, was I dreaming? Is this a dream? Is this for real? And I have to come back to the real world and say, yes, this is a pandemic. It's happening in my lifetime. Unbelievable. For some persons, depression. If you're feeling depressed, check that. And for other persons, frustration. As we cope with the lockdowns, the fact that we have to be remaining home, we can't socialize as we used to. And a big one for many persons, grief. Because, you know, grieving is a natural response to loss, be it loss of your job, for persons who've lost family members, loss of a family member, loss of the things that we have been accustomed to doing, yes? Just our daily routine and interacting with people. And so I want us to name our feelings. And if you have any other feelings, just write them down. Because it's important that we deal with these feelings. We have to name them, claim it, and tame it. And I want us to repeat it wherever you are, right? You may be in a room by yourself, and if somebody hears you saying that, they may think you're going mentally ill, right? But just smile about it. So everybody repeat it. We're going to name it, claim it, and tame it. I want to remind us in these times to be compassionate with yourself, right? Remind ourselves that our feelings are normal and natural. And when we have these emotions and we go through this emotional roller coaster, it's not a sign of weakness. We have these feelings because we're human, right? In much the same way, cars run on fuel, human beings run on feelings. So we must name it, claim it, and tame it. I want to encourage us to live now in the present. Let's not think about next week, next year. Focus on the here and now. And you know something? Let us be grateful that we're at a place, we're alive. We can be listening to this discussion. Yes? Let us focus on the here and now. And we have to learn to accept those things over which we have no control and focus on the things that we can control. And to remind ourselves that tough times don't last, but tough people do. Let's repeat that. Affirm it in your consciousness. Tough times don't last, tough people do. I just want to turn to our healthcare providers. And I'm numbered among healthcare providers. We're on the front line, some of us more so than the others, and I want to commend my colleagues who are on the front line. They're exposed to the COVID virus on a daily basis. They leave their homes in the morning, I'm sure thinking about the possibility of illness or even death. They're working long hours. Many of them suffer from burnout, or maybe close to that point. They're away from their family. It must be very difficult for them. And I want us to pause wherever we are at this point in time and applaud them for the fantastic job that they're doing, right? Our healthcare workers, right? And it's important that we also help to protect them by staying home. And so, to our healthcare providers and all of us, I just remind us to ensure self-care, take care of self, ensure we're having adequate rest, we engage in physical activity as best as possible, pay attention to our diet, and manage stress, whatever way you learn to do it, whether through physical activity, through your spirituality, prayer, relaxation techniques, manage stress, especially during these difficult and uncertain times. It's important that we filter the news. News today can be very confusing, sometimes scary, hopeless. I'm sure you find that that's your experience. Certainly it's mine. And what we have to do in these uncertain times, confusing times, is that we have to set limit on television watching, being on the internet or social media time. It's very important. And sometimes it's important for us to decrease the conversation. Somebody calls you. Next time you get the call and somebody wants to talk to you about COVID, tell them you want to take a break from that. You want to think about something positive. Yes? We have to shift the conversation sometimes. And remember, your actions count. Everybody, we must take responsibility for our actions. And I'm not going to go through these. We know the things that we need to do. And I know many of us have been doing a great job here in terms of our hygiene, respiratory etiquette, avoiding close contact, staying home if sick, cleaning objects and surfaces. Very good. And I want us to pat ourselves on our shoulder for the fantastic job that we're doing. Everybody, it's a butterfly hug. Excellent, right? And let us remember our actions count. Let's continue to do that. I want us to remember that it's important in these times of physical distancing to remain connected. And we can do that through whatever way works for us. Telephone, text, social media, chat rooms, Zoom, WhatsApp, etc., right? But let's remember to stay connected. And as we try to stay connected, I want us to pause wherever we are and to sing with me. I can't sing, but I will read the words. We're going to have a sing-along. Reach out and touch somebody's heart, not hands. Make this world a better place. So everybody, reach out and touch somebody's, make this world. Excellent, right? Now we're going to sing this along throughout the COVID season, right? Reaching out and just touching somebody's heart and making this world a better place. It will be a better place. We have to remember to cultivate an attitude of gratitude. I want us today to, in a very solemn way, just count your blessings. The fact that you're here, you're celebrating life, we're alive, right? And to remember that gratitude will help us through these times. And as I come to an end, you know, the mobile phone, telephone is a wonderful device. And for it to function, we have to keep it charged so that we can be connected. And I just want to encourage us, just stay charged and be connected. And I want to say to everybody, thank you. Take responsibility for your lives. Therein lies the hope.
Thank you very much, Professor Abel. Very encouraging words from our Professor of Mental Health, and certainly an encouragement for us. Professor Abel, I have a question from a member of our audience who says that I had COVID-19, I was discharged from hospital, I was tested negative, and I'm now fully recovered. But a lot of my family and friends are not as close to me as they used to. I'm now a bit depressed, even though I've recovered from COVID-19. Don't know if you can speak to that person for us.
Thank you for that question. I'm glad and I'm celebrating with you that you're much better today. Yes, and therein lies the hope. Unfortunately, a lot of persons who have tested positive, have become ill, or persons who have been in contact with persons who've tested positive experience some amount of stigma and discrimination, right? And this is born out of fear on the part of other persons. And probably, I mean, just a need for them to protect themselves. And I think we have to recognize that other people, it's not that they want to reject us, it's not that they don't care for us, but they just want to protect themselves. And it's understandable that you would feel depressed. And I probably should have touched on that earlier, that for all of us, but more so persons who have been affected, we're at great risk of longer-term psychiatric problems such as depression, chronic anxiety problems. Other persons may develop post-traumatic stress disorder. It's a possibility, especially for our healthcare workers who are on the front line, working day in, day out. Other persons may even develop conditions such as obsessive compulsive disorder. Now that we have to be washing our hands and going through this routine continuously, for some persons, it may become an obsession, right? And they have difficulty coping with it, yes? So a whole host of psychiatric, mental health problems may develop. And you're highlighting the fact that you are getting depressed. Just to remind you that depression is a common disorder, and what you need to do is to reach out to mental health provider, yes, to your mental health provider, so that we can do a proper evaluation and to determine what sort of support you need, whether it's going to be talk therapy or you need to be on medication or whatever, right? But just encourage you to keep faith, keep hope alive, do the things that work for you, whether it's prayer, relaxation technique, whatever, right? But just to recognize that it's not, depression is a possibility here. And so I'm really thankful that you've shared this with us, and really happy to have clarified some issue.
Thanks very much, Prof. We are really prompted and pushed by your talk to leave with hope as we approach Code Red, and depending on where your situation is, all of the issues you raised with the fear and so on, that even as we physical distance, and you said, I think Prof. Scherer said it, that for the elderly, she doesn't like the word social distancing. As we distance ourselves physically and protect ourselves from the virus, we are going to be encouraged, Prof. I'd leave with this to say, reach out and touch somebody's heart and make this world a better place. It's okay to touch the heart at this time. So thank you very much, Professor Wendell Abel. A very able presentation, if I may say so, this morning at our COVID-19 pandemic conference. Thank you. Ladies and gentlemen, we've had a wonderful morning going into the afternoon for our COVID-19 pandemic conference. We chose the title, Approaching Code Red, signifying that we are about to approach, if some people will argue that we're there, but certainly a heightened stage of engagement with respect to the pandemic. The last time we met, we spoke about preparedness, and I must say that preparedness is always on the table, because we prepare early, but we must continue to prepare right through this phase of the pandemic. Today we had a range of speakers. We had excellent speakers. And I think you'll agree with me that what they brought to the table was that sense of heightened awareness and deeper engagement with respect to the management of the pandemic. If you have felt anxious, if you have felt scared, afraid, if you have felt depressed, then I hope that today what the University of the West Indies here in Jamaica has brought to you is, one, credible information, and around that a sense of hope and a sense of we can, yes we can. And certainly when we hear of the efforts being put forward, when we hear of the intellectual thought, when we hear of the thought leadership, and the kind of expertise that we have, it certainly brings to my mind a sense that we can have success over the containment, mitigation, and control of the COVID-19 pandemic, not only in Jamaica, but in our Caribbean region. Our university, and again I mentioned our Vice Chancellor, Sir Hilary Beckles, is a regional man. In fact, he's a global man. And what the university does at times like these, in these crises, is important in terms of the impact that it has globally. We have come together as a region. We have come together as academics. We have come together with partnership with ministry, with government, with the public health system to make an impact on COVID-19. And I'm happy today that we're leaving this conference with that sense of solidarity. We heard about it. We heard that from previous speakers. Professor Figueroa, even the sense that we're engaging in the solidarity trial, WHO trial, says that we are in this together. We heard the words of Professor Abel saying that hope is alive and hope is there. and we are in this together. So as we close, I want to encourage everyone to look after yourselves, look after your families, look after your community. Let us continue to love and protect ourselves as we love and protect each other. And as Prof. Abel encouraged us to do, reach out and touch, not somebody's hands, social distancing is still there, but reach out and touch somebody's heart. So maybe what we're saying, physical distancing is there, but social connection, reach out and touch somebody's heart. Let's help somebody today as we go forward. As I close, I want to say thanks to all of our speakers, all of our distinguished panelists who came, presented, took the time. It's a busy time for many of our speakers, but they took the time to present. On your behalf, I want to thank them and to really wish them well and show appreciation for their support. I want to say a special word of thanks to Professor Celia Christie, who is a visionary, really. She spoke, you heard her speak earlier, on the natural history of COVID-19, but she's really the force and the vision behind a lot of what we're doing at this time in terms of getting this scientific information out, pushing the university to be forward-thinking and to provide information to the public. So a special thanks to Prof. Christie for her leadership and for her vision. I want to thank the Mona Information Technology Service team, in particular the UE Mona Media team. That's a special group that we have, and I must big them up. They have taken the time out of a situation where some of them should really be looking after themselves now and doing stuff, but they've come and helped us to get this show on the road. And I also want to thank, in addition, my faculty of medical sciences team, in particular, Mr. Damian Brown, Ms. Sharon Roberts, for their support. Ladies and gentlemen, I want to lastly thank you for tuning in. Thank you for clicking on the link and participating. Thank you for your questions. We'll try as we go forward to look at all your questions. I know we have a wide range of comments and questions, and as a university, we promise to respond to this. But take care of yourselves. Let's go forward in solidarity as we fight this COVID-19 pandemic. God bless.